Hey everyone, and welcome. If you're here, chances are you're a nursing student, which means you've probably got a textbook sitting on your desk that's heavy enough to be used as a self-defense weapon. You've flipped through the pages and seen thousands of new words, words you can barely pronounce, let alone remember. And you might be feeling that classic nursing school cocktail of excitement, terror, and pure, unfiltered overwhelm. I want you to take a deep breath. You are in the right place. Because today, we're not just starting a lesson. We're starting a journey. We're going to demystify that giant textbook. We're going to take the subject of human anatomy, which can feel like memorizing a dictionary in a foreign language, and turn it into your greatest asset as a future nurse. This isn't about passing a test. This is about building the fundamental knowledge that will separate a good nurse from a truly exceptional one. Think about it. Why do you, as a nurse, need to know the difference between the sartorius and the gastrocnemius muscle? Who cares what the circle of Willis is? It's a fair question. The answer is simple. Your patients care. They may not know it, but every single thing you will do for them, from the most basic task to the most critical intervention, is rooted in anatomy. When you start in 4, you're not just blindly poking for a vein. You're looking for the cephalic or basilic vein in the antecubital fossa, and you're consciously avoiding the brachial artery that runs nearby. When you listen to a patient's lungs, you're not just placing your stethoscope randomly. You're listening over the superior and inferior lobes, trying to distinguish the sounds of the bronchi from the alveoli. When a doctor orders you to insert a Foley catheter, you need to know the precise anatomical path of the urethra to do it safely and without causing harm. Anatomy is your map. It's the detailed, intricate, and beautiful blueprint of the human body. Physiology, which is how it all works, is the traffic moving through the city on that map. And pathophysiology, the study of disease, is what happens when there's a traffic jam, a bridge collapse, or a wrong turn. You cannot possibly understand the traffic problems if you don't first know the map. So, let's start with learning how to read that map. In the world of anatomy, we have a universal starting point, a standardized reference that ensures every healthcare professional, whether they're in Toronto or Tokyo, is talking about the exact same thing. It's called the anatomical position. It sounds fancy, but it's incredibly simple. Imagine a person standing up straight, looking forward. Their feet are flat on the floor and close together. Their arms are at their sides. And here's the slightly weird part. Their palms are facing forward, with the thumbs pointing away from the body. That's it. That is the anatomical position. Every single directional term we use from this point forward assumes the body is in this position. It doesn't matter if your patient is lying on their side, curled up in a ball, or doing a headstand. In your mind, when you describe a location on their body, you are mentally picturing them in this upright, palms forward position. This creates a standard that prevents any confusion. Now that we have our starting position, we can learn the directions. These are your compass points for the human map. Let's go through the most important pairs. First up, superior and inferior. Superior means toward the head or upper part of a structure. Your head is superior to your shoulders. Inferior means away from the head or toward the lower part of a structure. Your knees are inferior to your hips. Simple, right? Think of a superior officer being a higher rank. Next, anterior and posterior. Anterior refers to the front of the body. Your breastbone, the sternum, is anterior to your heart. Posterior refers to the back of the body. Your spine is posterior to your stomach. A good way to remember this is that post often means after or behind. Then we have medial and lateral. This pair has to do with the midline of the body, an imaginary line that runs right down the middle, splitting you into left and right halves. Medial means closer to that midline. Your nose is medial to your eyes. Lateral means farther from the midline. Your ears are lateral to your nose. So when a patient has pain in the lateral aspect of their ankle, you know immediately they mean the outside of the ankle. Let's do 2 more crucial pairs, proximal and distal. These terms are used almost exclusively for the limbs, your arms and legs. Proximal means closer to the point of attachment or origin of the limb. Your elbow is proximal to your wrist because it is closer to where the arm attaches at the shoulder. Distal means farther from the point of attachment. Your fingers are distal to your wrist. Think distal for distant. This is hugely important when you're documenting wounds or assessing circulation. A weak distal pulse in the foot is a major warning sign. Finally, superficial and deep. Superficial means closer to the surface of the body. Your skin is superficial to your muscles. Deep means farther from the surface. Your bones are deep to your muscles. When you get a cut, a superficial wound only affects the skin, while a deep wound might hit muscle or even bone. I know, it feels like a lot of vocabulary, but practice this. Point to your own body. The clavicle is superior to the sternum. The scapula is posterior to the ribs. The humerus is proximal to the radius. The more you use these words, the more they become second nature. You're not just memorizing, you're learning the language. Now that we have our directions, let's talk about how we view the map. We can look at the body in different slices, or views called anatomical planes. There are three main ones you absolutely need to know, especially for understanding medical imaging like CT scans and MRIs. First is the sagittal plane. This plane divides the body vertically into right and left parts. If the slice is perfectly down the midline, it's called a mid-sagittal plane. If it's off-center, it's a parasagittal plane. Imagine a saw cutting you straight down from the top of your head, separating your right arm from your left arm. That's a sagittal cut. Second is the frontal plane, also called the coronal plane. This one also divides the body vertically, but into anterior and posterior parts, a front half and a back half. Imagine a pane of glass dropping down and separating the front of your face from the back of your head. That's a frontal plane. Third is the transverse plane, also called a horizontal or cross-sectional plane. This one runs horizontally, from right to left, dividing the body into superior and inferior parts, a top half and a bottom half. This is the view you see most often in CT scans, like looking at slices of a loaf of bread. Understanding these planes is your key to interpreting diagnostic images. When a radiologist says there is a mass in the superior aspect of the right lung on a transverse view, you will be able to picture exactly where that is. So let's recap. We've established our universal starting point, the anatomical position. We've learned our compass directions, superior/inferior, anterior/posterior, medial/lateral, proximal/distal, and superficial/deep. And we've learned the three ways to slice up the map: sagittal, frontal, and transverse planes. This is your foundation. This is the grammar of anatomy. Everything else we build in this series will rest on these core concepts. So review them, practice them, and get comfortable with them. Because next, we're going to take our map and put it under a microscope. We're going to zoom in from the big picture of the body all the way down to the smallest living units that make it all possible, the cells. We'll explore the tiny city that exists within each and every one of us, and how its structure is the starting point for everything. Thank you for starting this journey. Trust the process, stick with it, and I promise you, this knowledge will empower you every single day of your nursing career. I'll see you in the next part. Welcome back to our journey into human anatomy. In the last part, we learned how to read the map of the body. We covered the anatomical position, the directional terms that act as our compass, and the planes that give us different views. We looked at the body from a big picture, or gross anatomy, perspective. Now, we're going to do something amazing. We're going to zoom in. Way in. We're going past the organs, past the tissues, all the way down to the fundamental building block of life, the cell. If the human body is a massive, bustling metropolis, then the cell is a single, remarkable building. And you are made of an estimated 37 trillion of these buildings. Understanding the basic structure of this building is essential because every single thing that happens in the body, from a thought to a muscle contraction to fighting off a cold, happens first at the cellular level. When your patients are sick, it's because something has gone wrong in their cells. The drugs you give them are designed to fix things inside their cells. This isn't just abstract biology. This is the very foundation of medicine. So let's take a tour of a typical human cell. We'll call it a generalized cell because, in reality, cells are highly specialized. A nerve cell looks wildly different from a skin cell, which looks nothing like a red blood cell. But they all share a few common, essential components. Think of it like how every house needs walls, a door, and a power source, even if one is a mansion and another is a tiny cabin. The first thing you'll notice is the outer boundary, the walls of our building. This is the plasma membrane, or cell membrane. But this isn't a rigid brick wall. It's more like a sophisticated, intelligent security fence. It's made of something called a phospholipid bilayer, 2 layers of fat molecules, that is both flexible and strong. Its primary job is to separate the inside of the cell, the intracellular environment, from the outside world, the extracellular environment. But its most important feature is that it is selectively permeable. That means it controls what gets in and what gets out. It has special protein channels and gates embedded in it, like tiny doors and security checkpoints. Nutrients, like glucose, need a special key to get in. Waste products are actively escorted out. Water can move back and forth, but the membrane controls how much. This is a concept you will live and breathe as a nurse. Fluid and electrolyte balance, which is critical to patient health, is all about what's happening at the plasma membrane of trillions of cells. When you give a patient an saline solution, you are directly manipulating the environment outside their cells to influence what happens inside. Now, let's step inside our cellular building. The entire internal space is filled with a gel-like substance called the cytoplasm. It's mostly water, but it's packed with salts, nutrients, and all the cell's machinery. It's the factory floor where the work of the cell gets done. And floating around in this cytoplasm are tiny, specialized structures called organelles. Each one is like a different department in our factory, with a very specific job. Let's head to the main office, the control center of the whole operation. This is the nucleus. The nucleus is the largest organelle and is usually easy to spot. It's a sphere that contains the cell's most precious cargo, the DNA. This is the blueprint for the entire body. Every instruction for building proteins, for cell division, for everything the cell will ever do, is stored here in the form of chromosomes. As a nurse, you'll encounter diseases that are rooted in genetic problems, errors in the blueprint within the nucleus, like in cystic fibrosis or sickle cell anemia. Now, every factory needs power. The power plants of the cell are the mitochondria. These are small, bean-shaped organelles, and their job is cellular respiration. They take nutrients, like glucose and oxygen, and they convert them into the main energy currency of the cell, a molecule called ADP, adenosine triphosphate. Cells that do a lot of work, like muscle cells and nerve cells, are packed with thousands of mitochondria. When you hear about a patient's metabolism, you're really talking about the collective efficiency of all the mitochondria in their body. Some poisons, like cyanide, are deadly precisely because they shut down the mitochondria, causing a complete, body-wide power failure. Next, let's visit the manufacturing department. This is the ribosome. Ribosomes are tiny little specks, sometimes floating free in the cytoplasm and sometimes attached to a larger structure. Their job is to read the instructions sent from the nucleus and build proteins. They are the actual assembly line workers. Proteins do everything. They form structures. They act as enzymes to speed up chemical reactions. They carry signals. Your hair, your muscles, the antibodies that fight infection, it's all protein, and it's all built by ribosomes. Many of these ribosomes are attached to a network of folded membranes called the endoplasmic reticulum, or ER. There are two types. The rough ER is studded with ribosomes, which is why it looks rough. It's a protein-producing and modifying factory. The smooth ER, which has no ribosomes, has different jobs depending on the cell. In liver cells, for example, the smooth ER is crucial for detoxifying drugs and poisons. This is why liver function is so important to consider when you administer medications. Once proteins are made in the ER, they need to be sorted, packaged, and shipped to their final destination. This is the job of the Golgi apparatus, or Golgi complex. Think of it as the cell's post office or shipping department. It receives proteins and lipids from the ER, puts the finishing touches on them, and packages them into little bubbles called vesicles. These vesicles then travel to the plasma membrane to release their contents outside the cell, or they travel to other organelles within the cell. Finally, let's look at the cleanup crew. These are the lysosomes. Lysosomes are small, spherical vesicles filled with powerful digestive enzymes. They are the cell's recycling center and garbage disposal. They break down old, worn-out organelles, destroy invading bacteria or viruses, and can even, in a process called apoptosis, trigger the controlled self-destruction of the cell when it's old or damaged. This is a vital process for preventing cancer. So, you have the plasma membrane, security, the cytoplasm, factory floor, the nucleus, CEO's office with the blueprints, the mitochondria, power plants, the ribosomes, assembly workers, the ER, manufacturing plant, the Golgi apparatus, shipping department, and the lysosomes, cleanup crew. This intricate, coordinated city is happening inside you. right now, trillions of times over. When we talk about anatomy, it's not just about the big structures you can see and touch. It's about understanding that every organ, every muscle, every bone is made of these incredible cellular cities, all working together. Next time, we're going to see how these individual cellular buildings come together to form larger communities. We'll explore how cells with similar functions group together to form the four primary types of tissues, the fundamental fabrics that weave together to create the human body. We'll move from the single building to the entire neighborhood. I'll see you there. In our last part, we took a deep dive into the microscopic world of the cell. We toured the cellular city, meeting the organelles that act as the power plants, factories, and control centers that make life possible. But a city isn't just one building. It's a collection of buildings organized into neighborhoods. In the same way, the body isn't just a random soup of 37 trillion cells. These cells are organized into specialized communities called tissues. A tissue is simply a group of similar cells that work together to perform a specific function. The study of tissues is called histology, and while it might seem like a topic for lab researchers, having a basic understanding of it is incredibly practical for you as a nurse. It helps you understand everything from how skin heals to why a sprained ankle swells up. There are four, and only four, primary types of tissue in the entire human body. Everything, your brain, your bones, your heart, your skin, is made from some combination of these four fabrics. They are epithelial tissue, connective tissue, muscle tissue, and nervous tissue. In this part, we're going to tackle the first two, epithelial and connective tissue. They are the body's coverings and its support system. Let's start with epithelial tissue, or epithelium. If you have to remember just one key concept for epithelial tissue, it's this: it covers and lines. That's its main job. Epithelial tissue covers the entire surface of your body. That's your skin. It also lines all the body cavities and hollow organs. The inside of your mouth, your stomach, your intestines, your bladder, your blood vessels, they are all lined with a layer of epithelial tissue. It forms a boundary between your body and the external environment, and between different internal compartments. Epithelial tissues have some very distinct characteristics. First, the cells are packed together in tight, continuous sheets. There's very little space between them. Think of them as perfectly fitted tiles on a floor. This makes them excellent barriers. Your skin, for example, is an epithelial barrier that keeps bacteria out and water in. Second, epithelial tissues always have a free surface, called the apical surface, that is exposed to the body's exterior or the cavity of an internal organ. The other side, the bottom surface, is called the basal surface, and it's attached to a basement membrane, which acts like a glue anchoring the epithelium to the underlying tissue. Third, epithelial tissues are avascular. This is a hugely important word. It means they have no blood vessels of their own. So how do they get oxygen and nutrients? They are nourished by diffusion from the blood vessels in the connective tissue that lies just underneath them. This is why a very shallow paper cut might not bleed. You've only sliced through the avascular epithelium. A deeper cut that bleeds has reached the vascular connective tissue below. We classify epithelial tissues based on two criteria: the shape of the cells and the number of cell layers. The shape can be squamous, flattened, like a fried egg, cuboidal, cube-shaped, like dice, or columnar, tall and thin, like a column. The number of layers can be simple, a single layer of cells, or stratified, multiple layers of cells stacked on top of each other. By combining these, we get names that tell us exactly what the tissue looks like. For example, simple squamous epithelium is a single layer of flat cells. Because it's so thin, it's perfect for places where rapid diffusion needs to occur, like the tiny air sacs, alveoli, in the lungs where oxygen and carbon dioxide are exchanged, and the lining of capillaries. Stratified squamous epithelium is multiple layers of flat cells. This is a tissue built for protection against abrasion. The most obvious example is your skin. The outer layers are constantly being sloughed off and replaced by the layers below. You'll also find it lining the mouth and esophagus, protecting you from rough food. Simple cuboidal epithelium is a single layer of cube-shaped cells, often found in glands and in the kidney tubules where secretion and absorption are key functions. Simple columnar epithelium, a single layer of tall cells, lines most of the digestive tract, from the stomach to the intestines. These cells are specialized for absorption of nutrients and secretion of mucus. Understanding this helps you understand function. When you see stratified, think protection. When you see simple, think absorption, secretion, or diffusion. Now, let's switch gears to our second type of tissue, connective tissue. If epithelial tissue covers and lines, connective tissue supports and connects. It is the most abundant and widely distributed tissue type in the body. It's found everywhere. Your bones, your cartilage, your fat, and your blood are all specialized forms of connective tissue. Unlike epithelial tissue where cells are packed tightly together, connective tissue cells are scattered far apart. What fills the space between them? A substance called the extracellular matrix. This matrix is the key to understanding connective tissue. It's made of two main components: a ground substance, which can be anything from a liquid to a gel to a solid, and protein fibers. The nature of this matrix determines the tissue's qualities. There are three types of fibers found in the matrix. Collagen fibers. These are incredibly strong and provide high tensile strength, like steel cables. Elastic fibers. These are long and thin, and they can stretch and recoil like a rubber band. Reticular fibers. These are short, fine fibers that form delicate, branching networks, like a spider's web, to support soft organs. Let's look at a few examples to see how this works. One major class is connective tissue proper. This includes loose connective tissue, like a relar tissue. This is the most common type, a gel-like matrix with all three fiber types. It acts as a universal packing material, holding organs and water in place. It's the tissue that lies right underneath almost all epithelia. When you get an inflammation and the area swells up with fluid, edema, that fluid is accumulating in the areolar tissue. Another loose type is adipose tissue, which is basically fat. Its cells are filled with a large lipid droplet, and its main jobs are to store energy, insulate the body, and cushion organs. Then there is dense connective tissue, which is packed with collagen fibers. Dense regular connective tissue has the collagen fibers all running in the same direction. This makes it incredibly strong against pulling forces in one direction. Where would you need that? In tendons, which connect muscle to bone, and ligaments, which connect bone to bone. A sprained ankle is an injury to the ligaments, the dense regular connective tissue. Now for the more specialized types. Cartilage. Here, the matrix is a firm, gel-like substance. It's tough but flexible. You find it covering the ends of bones at joints, articular cartilage, in your nose, and in your ears. Cartilage is also avascular, like epithelium, which is why it heals very, very slowly. A torn cartilage in the knee often requires surgery because it can't repair itself well. Bone, or osseous tissue. This is connective tissue at its hardest. The matrix here is rock-like because it's filled with calcium salts, but it also has plenty of collagen fibers, which give it some flexibility so it doesn't shatter like chalk. Bones support and protect the body, and they are where our blood cells are made. Finally, and this might surprise you, blood. Blood is considered a connective tissue because it consists of blood cells, red, white, and platelets, surrounded by a fluid extracellular matrix, which we call plasma. Its fibers are soluble proteins that only become visible during clotting. Its function, of course, is to connect the whole body by transporting oxygen, nutrients, and waste. So we have epithelium, the great coverer and liner, forming protective barriers and absorptive surfaces. And we have connective tissue, the great supporter and connector, in all its diverse forms from liquid blood to solid bone. These two fabrics work together constantly. The skin is a perfect example, an outer layer of stratified squamous epithelium anchored to an underlying layer of areolar and dense, irregular connective tissue. Next time, we'll complete our tour of the four primary tissues by exploring the two excitable tissues: muscle tissue, which allows us to move, and nervous tissue, which allows us to think, feel, and control it all. We'll explore the fabrics that create action and communication in the body. See you then. We are continuing our exploration of histology, the study of the four primary tissues that form the fabric of the human body. In our last discussion, we covered the body's structural fabrics, epithelial tissue, which acts as our covering and lining, and the incredibly diverse connective tissue, which provides support and connection in forms ranging from liquid blood to solid bone. Today, we're diving into the final two tissue types: and these are the ones that generate the action and communication in our bodies. These are the excitable tissues. They have a unique ability to respond to stimuli by generating electrical signals. Let's get into muscle tissue and nervous tissue. First up, muscle tissue. When you think of muscle, you probably think about movement, and you're absolutely right. The defining characteristic of muscle tissue is its ability to contract or shorten. When muscle cells contract, they pull on whatever they're attached to and generate force, which produces movement. This is a highly specialized and very energy-intensive job. Muscle cells are packed full of mitochondria, the cellular power plants, to produce the vast amounts of ATP needed for contraction. There are 3 types of muscle tissue in the body, and as a nurse, you need to know the difference between them because they are located in different places, have different structures, and most importantly, are controlled in different ways. Let's start with the one you're most familiar with, skeletal muscle. This is the muscle that attaches to your skeleton, your bones. When skeletal muscle contracts, it moves your bones, allowing you to walk, run, lift things, and change your facial expressions. If you look at skeletal muscle cells under a microscope, you'll see they are very long, cylindrical cells. They are also multinucleate, meaning each cell has more than one nucleus. But their most obvious feature is the presence of striations. They have a striped or banded appearance. These stripes are formed by the precise arrangement of the contractile proteins inside the cells. The most important clinical fact about skeletal muscle is that it is under voluntary control. You consciously decide to contract these muscles. When you decide to pick up your coffee cup, your brain sends a signal down a nerve to the skeletal muscles in your arm and hand, and they contract. This is why conditions that affect the nerves controlling these muscles, like a spinal cord injury or ALS, can lead to paralysis. When you give an intramuscular injection, like a flu shot, you are injecting medication directly into skeletal muscle tissue, typically the deltoid in the shoulder or the gluteus medius in the hip. Next, we have cardiac muscle. As the name implies, this tissue is found in only one place in the entire body, the wall of the heart. Like skeletal muscle, cardiac muscle is also striated. However, its cells are quite different. They are shorter, branched, and have only one nucleus. A very special feature of cardiac muscle cells is that they are connected to each other by unique junctions called intercalated discs. These discs contain special proteins that hold the cells tightly together and also allow electrical signals to pass directly from one cell to the next. This lets the entire heart contract in a coordinated, wave-like motion, like a single, unified pump. Clinically, the most critical thing to know about cardiac muscle is that it is under involuntary control. You don't have to think about making your heart beat. It does so automatically, thanks to its own built-in pacemaker system. This is a very good thing. The health of this tissue is, quite literally, a matter of life and death. A heart attack, or myocardial infarction, occurs when the blood supply to the cardiac muscle is cut off and the tissue begins to die. Finally, we have smooth muscle. This tissue gets its name because, unlike the other two, it is not striated. It has no stripes. Its cells are spindle-shaped, with a single nucleus in the center. Smooth muscle is found in the walls of hollow organs throughout the body. Think of the stomach, the intestines, the bladder, the uterus, and the blood vessels. The function of smooth muscle is to squeeze substances through these organs by contracting and relaxing. This process is called peristalsis in the digestive tract. When your stomach growls, you're hearing your smooth muscle at work. When your pupils dilate or constrict in response to light, that's smooth muscle in your iris. And crucially, smooth muscle in the walls of your arteries and arterioles controls blood pressure by constricting or dilating the vessels. Like cardiac muscle, smooth muscle is under involuntary control. You don't consciously decide to digest your food or to regulate your blood pressure. Many medications, especially blood pressure medications, work by targeting the smooth muscle cells in blood vessel walls. So, to recap muscle tissue, skeletal is striated, voluntary, and moves the skeleton. Cardiac is striated, involuntary, and pumps the heart. Smooth is non-striated, involuntary, and moves substances through hollow organs. Now, let's move to our fourth and final tissue type, nervous tissue. If muscle tissue is the body's engine, nervous tissue is the computer and wiring that controls it. It is the main component of the nervous system. The brain, the spinal cord, and all the nerves that branch out from them. Nervous tissue has a singular, complex function: communication. It generates and transmits nerve impulses or electrical signals to and from all parts of the body, allowing us to respond to stimuli, process information, and control our body's functions. There are two major types of cells in nervous tissue. The stars of the show are the neurons. These are the actual nerve cells that conduct the electrical impulses. They are the longest cells in your body. A single neuron can stretch from your lower back all the way down to your big toe. Neurons have a unique structure. There is a cell body, which contains the nucleus and most of the organelles. Extending from the cell body are two types of processes. The dendrites are branching extensions that act like antennae. They receive signals from other neurons and carry them toward the cell body. Then there is a single, long axon, which carries the electrical signal away from the cell body to another neuron or to a muscle or gland. This flow of information from dendrite through the cell body down the axon is fundamental to how the nervous system works. The second type of cell in nervous tissue is far more numerous. These are the neuroglia, or glial cells. Think of these as the support staff for the neurons. They have many important jobs. They support and brace the delicate neurons. They insulate them. They provide them with nutrients. And they clean up waste and defend against pathogens. They don't conduct nerve impulses themselves, but without them, the neurons couldn't function. Conditions like multiple sclerosis, MS, are caused by damage to the myelin sheath, a fatty insulation produced by glial cells that surrounds the axons. When this insulation is damaged, nerve impulse transmission is slowed or stopped, leading to the symptoms of the disease. So, nervous tissue, with its communicating neurons and its supporting neuroglia, forms the master control system of the body. Every thought you have, every sensation you feel, every movement you make, is a product of this incredible tissue. And with that, we have now covered all four primary tissue types: the covering epithelium, the supporting connective tissue, the moving muscle tissue, and the controlling nervous tissue. Remember, these four fabrics are not isolated. They are woven together in intricate ways to form all the organs of the body. An organ, by definition, is a structure composed of two or more tissue types that performs a specific function. The stomach, for instance, has an inner lining of epithelium, a wall made of smooth muscle and connective tissue, and is controlled by nervous tissue. Understanding these four basic building materials is the key to understanding the structure of the organs we're going to be exploring next. We're ready to zoom back out from the microscopic level and start looking at the organ systems. And we'll begin with the body's largest organ system, the one that covers us from head to toe, the integumentary system. We'll explore the skin and its appendages, and you'll be amazed at how much this protective barrier can tell you about a patient's overall health. See you there. Over the last few parts, we've built our understanding of the human body from the ground up. We started with the basic language of anatomy, zoomed into the cellular level, and then saw how cells organize into the four fundamental tissues: epithelial, connective, muscle, and nervous tissue. Now, we're ready to see how these tissues come together to form organs and organ systems. And we're going to start with the largest organ of the body, one that you might not even think of as an organ: your skin. The skin, along with its accessory structures, hair, nails, and various glands, makes up the integumentary system. The word integument simply means covering, and that's its most obvious job. But this system is so much more than just a passive wrapper for your body. It's a dynamic, complex organ system that is absolutely vital for survival. As a nurse, the skin will be one of your most valuable assessment tools. It provides a window into the health of your patient, telling you stories about their circulation, their oxygen levels, their hydration, and even their nutritional status. Let's start by looking at the structure of the skin itself. The skin is composed of two main layers: the superficial epidermis and the deeper dermis. Just beneath the dermis is a layer called the hypodermis, which isn't technically part of the skin, but it anchors the skin to the underlying muscles. The epidermis is the outermost layer. What type of tissue do you think it is? If you guessed epithelial tissue, you're exactly right. Specifically, it's a stratified squamous epithelium. Stratified means it's made of multiple layers, which makes it perfect for its protective role. This layer is also avascular, meaning it has no blood vessels. All the nutrients it needs diffuse up from the dermis below. The epidermis is a bustling factory of cell production. The deepest layer is constantly dividing and producing new skin cells. As these new cells are made, they push the older ones up toward the surface. As the cells move up, they flatten out, fill with a tough, waterproof protein called keratin, and then they die. The outermost layer of your skin, the part you can see and touch, is actually composed of about 20 to 30 layers of dead, keratin-filled cells. This might sound a bit gross, but it creates a formidable barrier. It protects you from water loss, from mechanical abrasion, and from bacteria and other pathogens. You get a completely new epidermis every 25 to 45 days. Also found in the epidermis are cells called melanocytes. These cells produce the pigment melanin, which is what gives skin its color. But melanin's primary job isn't cosmetic, it's protective. Melanin forms a protective shield over the nucleus of the skin cells to protect their DNA from the damaging effects of ultraviolet, UV, radiation from the sun. The more sun exposure a person's ancestors had, the more melanin their skin is genetically programmed to produce. This is why skin color varies around the world. Now, let's go deeper to the dermis. The dermis is the hide of your skin. It's a strong, flexible layer of connective tissue. Unlike the epidermis, the dermis is packed with blood vessels, nerve fibers, and lymphatic vessels. This is the layer that bleeds when you get a deep cut. It has two main regions. The upper part has finger-like projections that push up into the epidermis, creating ridges. On the palms of your hands and the soles of your feet, these ridges are very large and form your fingerprints, which help with grip. The deeper part of the dermis is made of dense, irregular connective tissue and is filled with collagen and elastic fibers. The collagen fibers give the skin its strength, while the elastic fibers give it its ability to stretch and recoil. As we age, these fibers break down and the skin loses its elasticity, which is why wrinkles form. The dermis is also where you'll find the skin's accessory structures. Hair follicles are embedded here. A hair is essentially a flexible strand of dead, keratinized cells. Attached to each hair follicle is a tiny, smooth muscle called the erector pili. When you're cold or scared, this muscle contracts, pulling the hair upright and causing a goosebump. You'll also find two main types of glands in the dermis. Sebaceous glands, or oil glands, are found all over the body except the palms and soles. They produce an oily substance called sebum, which they secrete into the hair follicle. Sebum softens and lubricates the hair and skin and has bactericidal properties. Acne is an inflammation of these glands. The other type of gland is the sweat gland, or sudoriferous gland. There are two kinds. The most numerous are eccrine sweat glands. You have millions of them all over your body. They produce sweat, which is mostly water with some salts and metabolic wastes. The primary function of this sweat is thermoregulation. When your body temperature rises, these glands secrete sweat onto the skin's surface. As the sweat evaporates, it cools the body down. This is a vital homeostatic mechanism. The other type, apocrine sweat glands, are found mainly in the axillary, armpit, and anogenital areas. Their sweat is thicker and contains fats and proteins. It's odorless at first, but when bacteria on the skin decompose it, it creates body odor. Finally, beneath the dermis is the hypodermis, or subcutaneous tissue. It's mostly adipose tissue, or fat. It anchors the skin, acts as a shock absorber, and provides insulation. This is the layer that a subcutaneous injection is delivered into. So, let's quickly review the functions of this incredible system. Protection. It's a chemical barrier with its low pH and sebum, a physical barrier with its tough keratinized cells, and a biological barrier with immune cells. Body temperature regulation. Through sweating for cooling and by constricting blood vessels in the dermis to conserve heat when it's cold. Sensation. The dermis is full of sensory receptors for touch, pressure, temperature, and pain. Metabolic functions. Your skin synthesizes vitamin D when it's exposed to sunlight. This is essential for calcium absorption. Blood reservoir. The dermal blood vessels can hold about 5% of the body's entire blood volume. Excretion. A small amount of nitrogenous waste is eliminated in sweat. As a nurse, you'll be assessing the skin constantly. Is it pale, suggesting poor circulation or anemia? Is it blue, a condition called cyanosis, suggesting a lack of oxygen? Is it yellow or jaundiced, suggesting a liver problem? Is the skin turgor, its elasticity, poor? That's a key sign of dehydration. You'll also be the primary person responsible for preventing pressure ulcers or bed sores, which are injuries to the skin and underlying tissue resulting from prolonged pressure. Understanding the structure of the integumentary system is the first step to protecting it. Next up, we're going to move even deeper. We've looked at the covering. Now we're going to look at the framework it's all built upon. We're heading into the skeletal system. We'll explore the bones, joints, and cartilages that form the scaffolding of our bodies. We've just explored the integumentary system, the protective outer covering of our bodies. Now, we're going to strip that layer away and look at the remarkable framework that lies beneath, the skeletal system. When you hear skeleton, the first things that probably come to mind are support and structure, maybe even something a bit spooky from Halloween. But the skeletal system is a living, dynamic organ system that does so much more than just hold us up. It's composed of bones, cartilages, ligaments, and joints, and it provides the scaffolding for everything else in the body. For nurses, understanding the skeleton is fundamental. You'll be caring for patients with fractures, osteoporosis, arthritis, and you'll be responsible for positioning patients safely to prevent injury. A solid grasp of the bony landmarks is essential. Let's start with the primary organs of this system, the bones. An adult human has 206 bones, each a distinct organ. What are the functions of our bones? First, and most obviously, support. The bones of the legs, pelvis, and vertebral column hold up the body. The mandible, or jawbone, supports the teeth. Second, protection. The skull forms a protective case around the delicate brain. The vertebrae surround the spinal cord, and the rib cage protects the vital organs of the thorax, like the heart and lungs. Third, movement. We talked about how skeletal muscles move the body, but they can't do it alone. They need something to pull against. Bones act as levers, and the joints act as pivots or fulcrums. As muscles contract, they pull on the bones, and movement occurs. Fourth, mineral and growth factor storage. Bone is a reservoir for minerals, most importantly calcium and phosphate. The body maintains a very tight control over blood calcium levels because it's crucial for nerve transmission, muscle contraction, and blood clotting. When blood calcium gets too low, the body can draw calcium out of the bones to raise it. When it's too high, it can deposit excess calcium into the bones. Fifth, and this is a big one that often gets overlooked, blood cell formation. This process, called hematopoiesis, occurs in the red marrow of certain bones. In adults, the red marrow is found mainly in the spongy bone of the skull, ribs, sternum, vertebrae, and the heads of the femur, thigh bone, and humerus, upper arm bone. And finally, fat storage. Yellow bone marrow, which is found in the hollow cavity of long bones, is primarily made of adipose tissue and serves as an energy reserve. Now, let's talk about the structure of bone tissue itself. There are two types of bone tissue, or osseous tissue. Compact bone is the dense, smooth, and solid outer layer of every bone. It looks solid to the naked eye, but under a microscope, it's a complex system of tunnels and canals. The structural unit of compact bone is called an osteon, a series of concentric tubes of bone matrix. The other type is spongy bone, also called cancellous bone. It's found inside the compact bone. It's a honeycomb of small, needle-like or flat pieces called trabeculae. The open spaces between the trabeculae are filled with red or yellow bone marrow. This structure makes bones lighter without sacrificing too much strength. Bones can also be classified by their shape. Long bones are longer than they are wide. These are most of the bones in our limbs, like the humerus, radius, ulna, femur, tibia, and fibula. They act as levers. Short bones are roughly cube-shaped, like the bones of the wrist, carpals, and ankle, tarsals. Flat bones are thin, flattened, and usually a bit curved. Examples include the sternum, scapulae, shoulder blades, ribs, and most of the bones of the skull. They are often for protection or for broad muscle attachment. Irregular bones have complicated shapes that don't fit into the other categories. The vertebrae and the hip bones are good examples. Let's take a closer look at a typical long bone, like the femur. It has a long shaft, called the diaphysis. The diaphysis is a thick collar of compact bone that surrounds a central medullary cavity, which contains yellow marrow in adults. At each end of the bone is an epiphysis. The epiphyses are broader than the diaphysis. They have an outer shell of compact bone and an interior of spongy bone. The joint surface of each epiphysis is covered with a layer of smooth articular cartilage, which cushions the bone ends and allows for smooth movement. Separating the diaphysis and epiphysis in a growing child is the epiphyseal plate, or growth plate. This is a disc of cartilage that allows the bone to grow in length. Once a person stops growing, this plate is replaced by bone, leaving behind an epiphyseal line. Now, let's divide our 206 bones into two main groups: the axial skeleton and the appendicular skeleton. The axial skeleton forms the long axis of the body. It includes the bones of the skull, the vertebral column, and the thoracic cage, the ribs and sternum. Its main job is to support the head, neck, and trunk, and to protect the brain, spinal cord, and thoracic organs. The skull is formed by two sets of bones: the cranial bones, which enclose and protect the brain, and the facial bones, which form the framework of the face, house the sense organs, and provide attachments for facial muscles. You don't need to memorize every single one right now, but be familiar with the major ones: the frontal bone, forehead; the parietal bones, top and sides; the temporal bones, temples; and the occipital bone, back of the head. In the face, the maxilla, upper jaw, and mandible, lower jaw, are key. The vertebral column, or spine, is the body's central support. It's made of 26 irregular bones called vertebrae. It's divided into regions: 7 cervical vertebrae in the neck, C1, C7; 12 thoracic vertebrae in the chest region, T1, T12; and 5 lumbar vertebrae in the lower back, L1, L5. Below the lumbar vertebrae is the sacrum, which is 5 fused vertebrae, and at the very end is the tiny coccyx, or tailbone. Between the vertebrae are intervertebral discs made of cartilage, which act as shock absorbers. The thoracic cage consists of the thoracic vertebrae posteriorly, the ribs laterally, and the sternum and costal cartilages anteriorly. It protects the heart and lungs and supports the shoulder girdles. The appendicular skeleton consists of the bones of the limbs and the girdles that attach them to the axial skeleton. The pectoral girdle, or shoulder girdle, consists of the clavicle, collarbone, and the scapula, shoulder blade. It attaches the upper limbs to the axial skeleton. The upper limb consists of the humerus in the arm, the radius and ulna in the forearm, the carpals in the wrist, the metacarpals in the palm, and the phalanges in the fingers. The pelvic girdle, or hip girdle, is formed by the 2 hip bones, coxal bones. It's strong and stable, designed to bear the weight of the upper body. It attaches the lower limbs to the axial skeleton. The lower limb consists of the femur in the thigh, the largest, longest, strongest bone in the body, the patella, kneecap, the tibia, shin bone, and fibula in the lower leg, the tarsals in the ankle, the metatarsals in the foot, and the phalanges in the toes. I know that's a whirlwind tour and a lot of new names, but start to build this framework in your mind. Know the difference between axial and appendicular. Be able to name the major bones of the arm and leg. This knowledge is your foundation for understanding injuries like fractures, for locating anatomical landmarks for procedures, and for communicating clearly with other healthcare professionals. Of course, bones don't work in isolation. They are connected at joints, which allow for movement. So, in our next part, we're going to explore the world of articulations, or joints. We'll look at how they are structured, how they move, and what happens when they go wrong, as in arthritis. See you then. Last time, we laid out the entire framework of the body, exploring the 206 bones of the axial and appendicular skeletons. We learned that bones provide support, protection, and act as levers for movement. But a pile of levers is useless without pivots. The places where our rigid bones meet and connect are called joints, or articulations. Joints are the unsung heroes of the skeletal system, giving our skeleton mobility and holding it together. The study of joints is called arthrology, and understanding them is crucial for you as a nurse. You'll be helping patients who have joint injuries, who suffer from arthritis, or who have had joint replacement surgery. You will also be responsible for performing range of motion exercises to keep your patient's joints healthy. We can classify joints in 2 ways: by their structure, what they're made of, or by their function, how much they move. Functionally, they can be immovable, slightly movable, or freely movable. Structurally, we classify them as fibrous, cartilaginous, or synovial. For our purposes, the structural classification is the most useful. Let's start with fibrous joints. In these joints, the bones are united by dense fibrous connective tissue, and there is no joint cavity. Most fibrous joints are immovable. A classic example is the sutures of the skull. The bones of your cranium are locked together by these short connective tissue fibers. This provides incredible protection for the brain. As an infant, these sutures are wider and more flexible to allow for brain growth and to let the head deform slightly during birth, but they fuse as you age. Another type of fibrous joint is the one that holds a tooth in its socket in the jawbone. This is a very specialized peg-and-socket joint. Again, its primary purpose is strength and immobility. Next, we have cartilaginous joints. As the name suggests, in these joints, the articulating bones are united by cartilage. Like fibrous joints, they also lack a joint cavity and are not highly movable. There are two main types. The first is where a bar of hyaline cartilage unites the bones, like the epiphyseal plate, the growth plate, and the long bones of a child. These are temporary, immovable joints. The second type is where a pad or plate of fibrocartilage unites the bones. Fibrocartilage is highly compressible and a great shock absorber. The best examples in the body are the intervertebral discs between the vertebrae of the spine and the pubic symphysis, the joint between the two hip bones at the front of the pelvis. These joints allow for a small amount of movement. Your spine can bend, and the pubic symphysis has a little give, which becomes very important during childbirth. Now for the main event, synovial joints. These are the joints you probably think of when you hear the word joint. They are the freely movable joints, and they make up the vast majority of joints in the body. All the joints of our limbs, the shoulder, elbow, wrist, hip, knee, and ankle, are synovial joints. What makes a synovial joint unique is its structure. All synovial joints have 5 distinguishing features. Articular cartilage. The ends of the opposing bones are covered with a smooth layer of hyaline cartilage. This acts like Teflon, providing a slick, friction-reducing surface. Joint, synovial, cavity. This is a feature unique to synovial joints. It's a space between the articulating bones that is filled with synovial fluid. Articular capsule. The joint cavity is enclosed by a 2-layered capsule. The outer layer is a tough, fibrous layer that is continuous with the periosteum of the bones, providing strength. The inner layer is a synovial membrane, which is what produces the synovial fluid. Synovial fluid. This is a viscous, egg white-like fluid that fills the joint cavity. It's a lubricant that reduces friction between the articular cartilages. It also contains phagocytic cells that clean up microbes and cellular debris. When you crack your knuckles, you're causing gas bubbles to pop in this fluid. Reinforcing ligaments. Synovial joints are reinforced and stabilized by band-like ligaments, which connect bone to bone. Many synovial joints, like the knee, also have extra features like fatty pads for cushioning and discs of fibrocartilage called menisci, which improve the fit between the bone ends and help prevent side-to-side rocking. Now let's talk about movement. The incredible mobility of synovial joints allows for a wide range of motion. We have specific terms to describe these movements, and they always refer to movements in the anatomical position. Flexion and extension are common movements. Flexion is a bending movement that usually decreases the angle of the joint and brings the articulating bones closer together. Bending your head forward, bending your elbow, or bending your knee are all examples of flexion. Extension is the reverse of flexion. It increases the angle of the joint. Straightening a flexed neck, elbow, or knee are examples of extension. If you extend beyond the normal anatomical position, it's called hyperextension. Abduction and adduction are movements of a limb away from or toward the midline. Abduction is moving a limb away from the midline, like raising your arm out to the side or spreading your fingers apart. Think of abducting someone, taking them away. Adduction is the opposite. It's moving a limb toward the midline, like bringing your arm back down to your side. Think of adding the limb back to the body. Circumduction is moving a limb so that it describes a cone in space. If you hold your arm out and draw a circle on the wall, your shoulder is performing circumduction. It's a combination of flexion, abduction, extension, and adduction performed in succession. Rotation is the turning of a bone around its own long axis. You can rotate your head, as when you shake your head, no. You can also rotate your entire trunk. There are also many special movements that occur only at specific joints. For example, at the forearm, Supination is turning the palm to face anteriorly, like holding a bowl of soup, and pronation is turning the palm to face posteriorly. At the foot, dorsiflexion is lifting the foot up toward the shin, and plantar flexion is pointing the toes downward, like a ballet dancer. Understanding these movements is the basis of performing a range of motion assessment on your patients. When a patient has a condition like arthritis, which literally means inflammation of a joint, it's because the smooth articular cartilage has been damaged or worn away, leading to pain, stiffness, and a decreased range of motion. So, we have our rigid bony skeleton, and now we have the joints that connect them and allow for an incredible array of movements. But what actually creates the force to produce that movement? For that, we need to add the next layer to our system, the muscles. Up next, we'll dive into the gross anatomy of the muscular system and meet the major players that power our every action. We've built the body's framework with the skeletal system and connected it with the joints. Now it's time to add the engine. We're moving on to the muscular system. Specifically, we're going to focus on the gross anatomy of the skeletal muscles, the 600+ voluntary muscles that move our skeleton. We've already touched on the 3 types of muscle tissue: skeletal, cardiac, and smooth. The muscular system, however, refers almost exclusively to skeletal muscle. These muscles are the workhorses of the body, converting the chemical energy of ADP into mechanical energy or force. They allow us to walk, talk, breathe, and express our emotions. But they also have other vital functions. They help maintain our posture, they stabilize our joints by keeping tension on the tendons, and they generate a significant amount of our body heat. When you shiver in the cold, that's your skeletal muscles contracting rapidly to produce heat. To understand how muscles work, we need to know how they attach to bones. Almost all skeletal muscles are attached to bone or other connective tissue structures in at least 2 places. When a muscle contracts, one of these attachment points, the insertion, moves toward the other, more stationary attachment point, the origin. The origin is typically the more proximal attachment, while the insertion is the more distal one. For example, the biceps brachii muscle in your arm has its origin on the scapula and its insertion on the radius in the forearm. When it contracts, the radius is pulled toward the scapula and your elbow flexes. Muscles don't work in isolation. They work together, often in opposing groups, to produce smooth, controlled movements. The muscle that provides the major force for producing a specific movement is called the prime mover or agonist. The muscles that oppose or reverse a particular movement are called antagonists. The agonist and antagonist are located on opposite sides of the joint across which they act. For example, the biceps brachii is the prime mover for elbow flexion. Its antagonist is the triceps brachii, located on the posterior side of the arm. The triceps is the prime mover for elbow extension. While the biceps is contracting to flex the elbow, the triceps is relaxed and stretched. This is a fundamental principle of muscle action. We also have synergists, which are muscles that help the prime movers. They might add a little extra force to the same movement or, more commonly, they act as fixators to stabilize a bone or a joint, giving the prime mover a stable base to pull from. The names of skeletal muscles can seem intimidating at first, but they are often quite logical. Muscles are typically named based on one or more of several criteria, and if you understand the code, the name tells you a lot about the muscle. Location: some names indicate the bone or body region the muscle is associated with. For example, the temporalis muscle overlies the temporal bone. The brachialis muscle is in the arm, brachium. Shape: some muscles are named for their distinctive shape. The deltoid muscle of the shoulder is triangular, like the Greek letter delta, delta. The trapezius muscle in the upper back is shaped like a trapezoid. Size: terms like maximus, largest, minimus, smallest, longus, long, and brevis, short, are often used. Think of the gluteus maximus, the largest muscle of the buttock. Direction of muscle fibers: the names of some muscles refer to the direction in which their fibers run in relation to the midline of the body. Rectus means straight, rectus abdominis. Transversus means at a right angle, transversus abdominis. And oblique means at an angle, external obliques. Number of origins: when a muscle has more than one origin, or head, this is often in its name. The biceps brachii has 2 origins, and the triceps brachii has 3. Location of attachments: Some muscles are named according to their origin and insertion points. The sternocleidomastoid muscle of the neck, for example, has its origins on the sternum and clavicle and inserts on the mastoid process of the temporal bone. Action. Some muscles are named for the movement they produce. Words like flexor, flexes, extensor, extends, or adductor, adducts, will be part of the name. For example, the adductor longest muscle in the thigh is a long muscle that adducts the thigh. You don't need to memorize all 600 plus muscles, but as a nursing student, you should be familiar with the major muscle groups and some key individual muscles, especially those used for injections. Let's do a quick tour of some major muscles, starting from the head and moving down. In the head, we have muscles for facial expression, like the frontalis, wrinkles the forehead, and the orbicularis oculi, blinks and squints. For chewing or mastication, the major muscles are the masseter and the temporalis. In the neck, the sternocleidomastoid is the major muscle for flexing and rotating the head. The major muscles of the chest are the pectoralis major, which adducts and flexes the arm, and the intercostal muscles between the ribs, which are crucial for breathing. The back is dominated by the large trapezius, shrugs the shoulders, and the latissimus dorsi, extends and adducts the arm, as in swimming. The abdominal wall is made of layers of muscle. The rectus abdominis, the six-pack muscle for flexing the spine, and the external and internal obliques and transversus abdominis, which help rotate the trunk and compress the abdominal contents. The shoulder is capped by the deltoid, a prime mover for arm abduction and a common site for intramuscular injections. In the arm, the anterior compartment contains the biceps brachii, a powerful flexor of the elbow. The posterior compartment contains the triceps brachii, the prime extensor of the elbow. The buttocks are formed by the gluteal muscles, gluteus maximus, a powerful hip extensor for climbing stairs, gluteus medius, and gluteus minimus. The gluteus medius is another common injection site. The anterior thigh contains the massive quadriceps femoris group, the powerful knee extensors. The posterior thigh contains the hamstrings, which are the prime movers for knee flexion. In the lower leg, the posterior calf muscle is the gastrocnemius, or calf muscle, which plantar flexes the foot, the toe dancer's muscle. This is just a brief overview, but it starts to fill in the map. These muscles are the engines that move your skeletal levers at your synovial joints. But what tells these engines when to fire, how hard to contract, and in what sequence? For that, we need a control system. Next, we will begin our exploration of the most complex system in the body, the nervous system. We'll start with the basic organization and the cells that make it all happen. We've built a body with a bony framework, movable joints, and powerful muscles. It's an incredible machine, but it's just sitting there, waiting for instructions. Now we arrive at the system that provides those instructions, the nervous system. This is the body's master control and communication system. Every thought, every action, every emotion reflects its activity. It is, without a doubt, the most complex system we will study, but its basic organization is elegantly simple. The nervous system has three overlapping functions. First, it uses its millions of sensory receptors to monitor changes occurring both inside and outside the body. This is the sensory input. Second, it processes and interprets that sensory input and decides what should be done at each moment. This is called integration. Third, it causes a response by activating effector organs, our muscles or glands. This is the motor output. Imagine you are driving and see a red light ahead. Your eyes, sensory receptors, see the red light, the stimulus. This information is sent to your brain, integration. Your brain processes this information and makes a decision. Stop the car. It then sends a signal out to the muscles in your leg and foot, the effectors, to press the brake pedal, the response. This entire process, which happens in a fraction of a second, is the nervous system at work. Structurally, we can divide the nervous system into two main parts: the central nervous system, CNS, and the peripheral nervous system, PNS. The central nervous system consists of the brain and the spinal cord. It's the central command, or integration center. It interprets sensory input and dictates motor output based on reflexes, current conditions, and past experience. It is the seat of all your thoughts, memories, and emotions. The peripheral nervous system is the part of the nervous system outside the CNS. It consists mainly of the nerves that extend from the brain and spinal cord. Think of the PNS as the communication lines that link all parts of the body to the CNS. Spinal nerves carry impulses to and from the spinal cord, and cranial nerves carry impulses to and from the brain. We can break down the peripheral nervous system even further based on the direction the signals are traveling. The sensory, or afferent, division of the PNS consists of nerve fibers that convey impulses to the CNS from sensory receptors located throughout the body. The word afferent means carrying toward. This division keeps the CNS constantly informed of events going on both inside and outside the body. The motor, or efferent, division of the PNS transmits impulses from the CNS to effector organs, which are the muscles and glands. The word efferent means carrying away. These impulses activate muscles to contract and glands to secrete. In essence, they bring about the motor response. But we're not done yet. The motor division can also be subdivided. First, there's the somatic nervous system, often called the voluntary nervous system. It consists of somatic, motor nerve fibers that conduct impulses from the CNS to our skeletal muscles. This is the part of the nervous system that allows us to consciously control our muscles. When you decide to pick up a pen, that's your somatic nervous system in action. The other part of the motor division is the autonomic nervous system, ANS, also called the involuntary nervous system. The ANS consists of visceral motor nerve fibers that regulate the activity of smooth muscles, cardiac muscle, and glands. You can't control this system. It's the system that makes your heart beat faster when you're nervous, that makes your stomach digest food, and that makes you sweat when you're hot. It's on automatic pilot. Finally, the autonomic nervous system itself has two functional subdivisions that generally work in opposition to each other. The sympathetic division is the fight or flight system. It mobilizes the body during activity or emergencies. If you're in a stressful situation, your sympathetic nervous system will kick in, increasing your heart rate, raising your blood pressure, and sending more blood to your skeletal muscles so you're ready for action. Its counterpart is the parasympathetic division. This is the rest and digest system. It keeps body energy use as low as possible, directing housekeeping activities like digesting food and eliminating waste. When you're relaxing after a meal, your parasympathetic division is in charge. So, let's recap that organization because it's crucial. The entire nervous system is split into the CNS, brain and spinal cord, and the PNS, nerves. The PNS is split into the sensory, afferent, division, which sends signals in, and the motor, efferent, division, which sends signals out. The motor division is split into the somatic system, voluntary, controls skeletal muscle, and the autonomic system, involuntary, controls smooth muscle, cardiac muscle, and glands. And the autonomic system is split into the sympathetic, fight or flight, and the parasympathetic, rest and digest, divisions. As a nurse, this organizational map is your guide to understanding neurological conditions. A patient with a spinal cord injury has damage to the CNS. A patient with diabetic neuropathy has damage to the sensory nerves of the PNS. Many medications you administer will directly target the autonomic nervous system. For example, beta blockers work by blocking sympathetic effects on the heart to lower blood pressure. All of this incredible communication is carried out by the cells of nervous tissue, which we introduced earlier, the neurons and the neuroglia. The neuron is the structural unit of the nervous system, transmitting the electrical signals. A nerve, which is an organ of the PNS, is not a single neuron. It's a bundle of hundreds or thousands of neuron axons, all wrapped together in connective tissue, like a telephone cable containing many individual wires. Now that we have the big picture organization down, we're ready to explore the components. In our next part, we'll take a closer look at the central command itself. We'll journey into the brain and the spinal cord, the amazing structures of the central nervous system. We've just mapped out the grand organizational chart of the nervous system, distinguishing between the central and peripheral systems. Today, we're focusing on the headquarters, the absolute center of command and control, the central nervous system, CNS, which consists of the brain and the spinal cord. The CNS is where all the complex integration happens. It's where memories are stored, decisions are made, and consciousness resides. Because it's so vital and so delicate, it is encased in bone, the skull for the brain, and the vertebral column for the spinal cord. It's also protected by three connective tissue membranes called the meninges, and it's cushioned by a special fluid called cerebrospinal fluid, CSF. Inflammation of the meninges is called meningitis, a serious medical emergency you'll learn to recognize. Let's start at the top, with the brain. The adult brain is about the size of two fists put together and has the consistency of cold oatmeal, but it is the most complex object in the known universe. We can divide the brain into four major regions: the cerebral hemispheres, the diencephalon, the brainstem, and the cerebellum. The cerebral hemispheres, which together we call the cerebrum, are the most superior part of the brain and make up about 83% of its total mass. This is the part you typically picture when you think of a brain, with all its wrinkled ridges and grooves. The ridges are called gyri, and the shallow grooves are called sulci. These folds massively increase the surface area of the cerebrum, allowing for billions more neurons to be packed into the limited space of the skull. A deep groove, the longitudinal fissure, separates the cerebrum into right and left hemispheres. Each hemisphere has a thin, outer layer of gray matter called the cerebral cortex. Gray matter consists of neuron cell bodies, dendrites, and unmyelinated axons. This cortex is the executive suite of the nervous system, where our conscious mind is found. It enables us to be aware of ourselves and our sensations, to communicate, remember, understand, and initiate voluntary movements. The cerebral cortex is divided into four main lobes, each named for the cranial bone that overlies it. The frontal lobe, right behind your forehead, is involved with higher-level executive functions: personality, planning, decision-making, and conscious control of skeletal muscles, in an area called the motor cortex. The parietal lobe, at the top and back, is the primary center for processing sensory information like touch, temperature, and pain in the somatosensory cortex. The temporal lobe, on the sides by your temples, is involved with hearing, memory, and language comprehension. And the occipital lobe, at the very back, is the primary visual processing center. Deep within the cerebrum is the white matter, which consists of myelinated axons bundled into tracts. These tracts are the communication lines, carrying signals between different areas of the cortex and between the cortex and the rest of the CNS. Next, nestled deep inside the cerebrum, is the diencephalon. This includes three key structures. The thalamus is the great relay station for all sensory information coming into the cerebral cortex. The hypothalamus, despite its small size, is a major control center for body homeostasis. It regulates the autonomic nervous system, controls body temperature, food intake, water balance, and sleep-wake cycles. It's also the main link between the nervous system and the endocrine system. The third part is the epithalamus, which contains the pineal gland that secretes the hormone melatonin to help regulate sleep. Continuing downward, we find the brainstem. The brainstem provides the pathway for fiber tracts running between the higher and lower neural centers. It also contains the nuclei for 10 of the 12 pairs of cranial nerves. It has three regions: the midbrain, the pons, and the medulla oblongata. The medulla oblongata is the most inferior part, blending into the spinal cord. It is an absolutely crucial autonomic reflex center. It has a cardiovascular center that adjusts heart rate and blood vessel diameter, and respiratory centers that control the rate and depth of breathing. Damage to this area is often fatal. Finally, located dorsally, underneath the occipital lobe, is the cerebellum. The cerebellum is primarily involved in coordinating somatic motor activity. It processes input from the cerebral motor cortex and sensory receptors to provide the precise timing and patterns of skeletal muscle contraction needed for smooth, coordinated movements and agility. It's like the brain's quality control center for movement. When you're driving, typing, or playing an instrument, your cerebellum is hard at work. Now for the other half of the CNS, the spinal cord. The spinal cord extends from the medulla oblongata down to the level of the first or second lumbar vertebra. It's a two-way communication pathway. Sensory information travels up the cord to the brain, and motor commands travel down the cord from the brain to the effector organs. It's also a major reflex center. For example, the classic knee-jerk reflex is integrated within the spinal cord without any input from the brain. If you look at a cross-section of the spinal cord, you'll see a butterfly-shaped inner core of gray matter surrounded by an outer layer of white matter. the opposite arrangement of the brain. The gray matter contains the cell bodies of motor neurons and interneurons. The white matter consists of the myelinated axons, tracts, that are carrying information up or down the cord. 31 pairs of spinal nerves attached to the cord by paired roots. The dorsal roots contain sensory neurons carrying information into the cord, while the ventral roots contain motor neurons carrying commands out of the cord. Understanding this CNS anatomy is the key to localizing neurological deficits. If a patient has a stroke that damages the motor cortex in the left frontal lobe, they will likely have weakness or paralysis on the right side of their body because the motor pathways cross over. If a patient has a spinal cord injury at the level of the thoracic vertebrae, they will lose motor and sensory function in their legs, but their arms will be unaffected. Your anatomical knowledge will allow you to predict and understand these clinical presentations. Now that we've seen the command center, our next step is to look at the vast network of wires that connect it to every corner of the body, the peripheral nervous system. We'll explore the cranial and spinal nerves and take a closer look at the automatic pilot, the autonomic nervous system. In our last segment, we explored the incredible structures of the central nervous system, the brain and spinal cord, which serve as our body's integration and command center. But the CNS would be completely isolated without a way to communicate with the rest of the body. That communication network is the peripheral nervous system, PNS. The PNS includes all the neural structures outside the brain and spinal cord, sensory receptors, peripheral nerves, and their associated ganglia and motor endings. It's the system that provides the vital link between the CNS and the outside world, and between the CNS and our own bodies. Let's start with the nerves themselves. As we've said, a nerve is a cord-like organ of the PNS, consisting of a bundle of myelinated and unmyelinated peripheral axons enclosed by connective tissue. There are two main types of nerves, depending on where they arise: cranial nerves and spinal nerves. There are 12 pairs of cranial nerves that originate from the brain and brainstem. These nerves primarily serve the head and neck region. Each pair is identified by a Roman numeral, I through 12, and a name. Some of these nerves are purely sensory, like the optic nerve for vision. Some are purely motor, and some are mixed, containing both sensory and motor fibers. You will become very familiar with these in your clinical practice, especially during a neurological assessment. For example, you'll check cranial nerve 2, the optic nerve, by testing a patient's vision. You'll check cranial nerves 3, 4, and 6 by having them follow your finger with their eyes, as these nerves control eye movements. You'll assess cranial nerve 7, the facial nerve, by asking them to smile and puff out their cheeks. And you'll test cranial nerve 12, the hypoglossal nerve, by having them stick out their tongue. Each test gives you a piece of the puzzle about the health of their brainstem. The other type of nerve is the spinal nerves. There are 31 pairs of spinal nerves that arise from the spinal cord and exit through the openings between the vertebrae. They are named according to where they emerge from the spinal cord. 8 pairs of cervical nerves, 12 pairs of thoracic nerves, 5 pairs of lumbar nerves, 5 pairs of sacral nerves, and 1 pair of tiny coccygeal nerves. All spinal nerves are mixed nerves, meaning they carry both sensory and motor information. Soon after exiting the spine, each nerve branches. These branches then often join together with branches from other spinal nerves to form complex networks called nerve plexuses. The major plexuses are the cervical, brachial, lumbar, and sacral plexuses. These networks are important because they ensure that almost every muscle in a limb receives its nerve supply from more than one spinal nerve. So, damage to a single spinal nerve won't completely paralyze any limb muscle. The brachial plexus, for instance, is a massive network of nerves that provides almost all the innervation for the upper limb. Nerves like the radial, median, and ulnar nerves, which control the muscles of your arm and hand, all arise from this plexus. Now, let's revisit a critical division of the PNS motor system we introduced earlier, the autonomic nervous system, ANS. Remember, this is the involuntary, automatic system that controls our visceral functions, our heart rate, blood pressure, digestion, and glands. It is absolutely central to homeostasis. As a nurse, you'll find that a huge number of medications are designed to either mimic or block the effects of the ANS. The ANS has two divisions that work in a dynamic balance: the sympathetic and the parasympathetic. The sympathetic division is our fight or flight system. It's activated during times of excitement, exercise, or emergency. Think of the E situations: exercise, excitement, emergency, embarrassment. When the sympathetic system fires up, you see a predictable set of responses designed to prepare you for intense physical activity. Your heart rate and breathing rate increase. Your blood pressure rises. The bronchioles in your lungs dilate to let in more air. Your liver releases glucose into the blood for energy. Blood is shunted away from non-essential organs like the digestive system and skin and redirected to your skeletal muscles, brain, and heart. Your pupils dilate to let in more light. It's an all-out mobilization of the body's resources. The main neurotransmitter released by sympathetic fibers is norepinephrine, also called noradrenaline. The parasympathetic division, on the other hand, is our rest and digest system. It's most active when the body is at rest and is responsible for routine maintenance functions. Think of the D situations: digestion, defecation, and diuresis, urination. The parasympathetic system does the opposite of the sympathetic. It slows the heart rate, lowers blood pressure, and stimulates the activity of the digestive and urinary systems. Your pupils constrict. This division is all about conserving energy and directing housekeeping activities. The main neurotransmitter released by parasympathetic fibers is acetylcholine. Most visceral organs are served by both divisions of the ANS. They are said to have dual innervation. This allows for precise control over the organ's activity. The sympathetic division revs things up, and the parasympathetic division brings things back down. It's like having both an accelerator and a brake for your internal organs. For example, sympathetic stimulation speeds up the heart, while parasympathetic stimulation, via the vagus nerve, cranial nerve X, slows it down. Understanding this dual control is key to pharmacology. A drug that blocks sympathetic receptors on the heart, a beta blocker, will lower heart rate and blood pressure. A drug that stimulates parasympathetic receptors in the airways, used for asthma, will cause bronchodilation. So, the PNS is the vast network that keeps the CNS in touch with the entire body. Through the cranial and spinal nerves, it carries sensory information in and motor commands out. And through its remarkable autonomic division, it tirelessly manages all of our internal systems, keeping us in a state of balance without any conscious thought. We've now seen how the nervous system receives information. Next, we'll take a closer look at the specialized structures that gather that information in the first place. We'll explore the fascinating world of the special senses: vision, hearing, taste, and smell. We've journeyed through the central and peripheral nervous systems, understanding how they process information and send out commands. But all of that would be meaningless if the system had no way of gathering information in the first place. Today, we're going to explore how our body perceives the world around it and within it, focusing on the amazing anatomy of our special senses. The special senses, vision, hearing, balance, smell, and taste, are housed in complex sensory organs in the head. They provide us with a rich and detailed picture of our environment. As a nurse, you'll assess these senses constantly. You'll check a patient's vision, perform basic hearing tests, and note any changes in taste or smell, which can be important diagnostic clues. Let's start with the dominant sense in humans: vision. Our eyes are incredible organs. They are like sophisticated cameras that can detect light and convert it into electrical signals that the brain can interpret. Over 70% of all the sensory receptors in the body are in the eyes. The eye itself is a hollow sphere. Its wall is composed of 3 layers, or tunics. The outermost layer is the fibrous layer, which consists of the white, opaque sclera, the white of the eye, and the transparent cornea at the front. The sclera protects and shapes the eyeball, while the cornea is the crystal-clear window that lets light enter. The cornea does most of the light bending, or refraction, to focus the image. The middle layer is the vascular layer, or uvea. It includes the choroid, a blood vessel-rich membrane that nourishes all the eye layers. At the front, the choroid becomes the ciliary body, which contains a muscle that controls the shape of the lens. And most anteriorly, it becomes the iris, the colored part of the eye. The iris is a ring of smooth muscle that controls the size of the pupil, the central opening that regulates the amount of light entering the eye. The innermost layer is the retina. This is the light-sensitive layer. It contains millions of photoreceptor cells, the rods and the cones. Rods are very sensitive to light, and are best for peripheral and night vision. Cones operate in bright light and provide high-acuity color vision. When light hits the rods and cones, it triggers a chemical reaction that generates an electrical signal. This signal is then passed to other neurons in the retina and finally leaves the back of the eye via the optic nerve, cranial nerve 2, which carries the signal to the thalamus and then to the primary visual cortex in the occipital lobe to be interpreted as an image. When you shine a light in a patient's eye and check that their pupils are equal, round, and reactive to light and accommodation, PLAB, you are testing the entire pathway from the eye to the brainstem and back. Now let's move to the ear, which houses two special senses: hearing and equilibrium, balance. The ear is divided into three major areas: the external ear, the middle ear, and the internal ear. The external ear consists of the auricle, the part you can see, and the external acoustic meatus, the ear canal, which ends at the tympanic membrane or eardrum. The auricle funnels sound waves into the canal. The middle ear, or tympanic cavity, is a small, air-filled cavity inside the temporal bone. It's spanned by the three smallest bones in the body: the auditory ossicles, the malleus, hammer, incus, anvil, and stapes, stirrup. When sound waves hit the eardrum, it vibrates. The eardrum's vibrations are transferred and amplified by the ossicles and transmitted to the internal ear. The internal ear, also called the labyrinth, is a maze of bony chambers deep within the temporal bone. It has two main divisions. The snail-shaped cochlea is the organ of hearing. It contains a spiral organ with specialized hair cells. The vibrations from the ossicles cause the fluid inside the cochlea to move, which bends the hair cells. This bending opens ion channels and generates an electrical impulse, which is transmitted to the brain via the cochlear branch of the vestibulocochlear nerve, cranial nerve 8. The other part of the internal ear is the vestibular apparatus, which is responsible for our sense of equilibrium or balance. It consists of the vestibule and the semicircular canals. These structures contain hair cells that are sensitive to the position and movement of the head. When you tilt your head or spin around, you move the fluid and tiny crystals inside these chambers, which stimulates the hair cells. This information is sent along the vestibular branch of cranial nerve 8 to the brainstem and cerebellum, allowing you to sense your orientation in space and maintain your balance. Finally, let's briefly touch on the chemical senses: smell, olfaction, and taste, gustation. These senses are intertwined. What we call the flavor of food is largely dependent on its smell. The organ of smell is a small patch of specialized epithelium, the olfactory epithelium, located on the roof of the nasal cavity. It contains millions of olfactory sensory neurons. When we sniff, we draw air containing odor molecules across this epithelium. These molecules dissolve in the mucus and bind to receptors on the neurons, triggering an impulse that is sent to the brain via the olfactory nerve, cranial nerve I. The olfactory pathway is closely tied to the limbic system, the emotional part of our brain, which is why certain smells can trigger powerful memories and emotions. The receptor organs for taste are the taste buds, most of which are located on the tongue. Each taste bud contains gustatory epithelial cells that have long microvilli called gustatory hairs projecting through a taste pore. When food chemicals dissolve in saliva, they enter the taste pore and bind to receptors on these hairs. This triggers a signal that is transmitted to the brain, allowing us to perceive 5 basic taste sensations: sweet, sour, salty, bitter, and umami, a savory, meaty taste. These special senses provide us with an incredibly rich and detailed experience of our world. They are our windows and antennae. And now that we've covered the nervous system, the body's fast-acting electrical control system, it's time to look at its partner in command, the slow-acting chemical control system. Next up, we'll explore the glands and hormones of the endocrine system. So far, we've explored the nervous system, the body's rapid, wired communication network that sends electrical messages to control our actions. But there's another major control system that works alongside it, the endocrine system. While the nervous system is like a high-speed text message, the endocrine system is more like sending a letter through the mail. It's slower to start, but its effects are often much longer lasting. The endocrine system influences metabolic activity by means of hormones. Hormones are chemical messengers secreted by cells into the extracellular fluids. These messengers travel through the blood and regulate the metabolic function of other cells in the body. They control major processes like reproduction, growth and development, mobilization of body defenses, maintenance of electrolyte, water, and nutrient balance of the blood, and regulation of cellular metabolism and energy balance. The organs of the endocrine system are small, unimpressive-looking glands that are scattered throughout the body. Unlike exocrine glands, like sweat and salivary glands, which have ducts to carry their secretions to a membrane surface, endocrine glands are ductless. They release their hormones directly into the surrounding tissue fluid, where they are picked up by the blood or lymph. Let's take a tour of the major endocrine glands and the hormones they produce. We'll start with the master gland, the pituitary gland. This tiny, pea-sized gland hangs from the base of the brain and is connected to the hypothalamus. It has two lobes. The posterior pituitary doesn't actually make hormones. It stores and releases two hormones that are made by the hypothalamus. One is antidiuretic hormone, ADH, which tells the kidneys to reabsorb more water, preventing dehydration. The other is oxytocin, which stimulates uterine contractions during childbirth and milk ejection during breastfeeding. The anterior pituitary is a true hormone factory. It produces a whole host of hormones that regulate other endocrine glands. These include thyroid-stimulating hormone, TSH, which stimulates the thyroid gland, adrenocorticotropic hormone, ACTH, which stimulates the adrenal cortex, and two gonadotropins, follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which regulate the function of the gonads, ovaries, and testes. The anterior pituitary also makes growth hormone, GH, which is essential for growth, and prolactin, which stimulates milk production. Next, let's move down to the neck to find the thyroid gland, a butterfly-shaped gland located on the anterior neck, on the trachea just inferior to the larynx. The thyroid gland produces thyroid hormone, TH, which is actually two related iodine-containing hormones. Thyroid hormone is the body's major metabolic hormone. It affects virtually every cell in the body, increasing the basal metabolic rate and body heat production. It's also critical for normal skeletal and nervous system development. Hypothyroidism, too little TH, can cause weight gain, fatigue, and feeling cold. Hyperthyroidism, too much TH, can cause weight loss, anxiety, and a rapid heart rate. On the posterior side of the thyroid gland are 4 to 8 tiny glands called the parathyroid glands. These secrete parathyroid hormone, PTH, which is the single most important hormone controlling the calcium balance of the blood. When blood calcium levels get too low, PTH is released. It stimulates osteoclasts to break down bone and release calcium into the blood. It enhances reabsorption of calcium by the kidneys, and it promotes activation of vitamin D, which increases absorption of calcium by the intestines. Sitting atop the kidneys are the paired adrenal glands. Each adrenal gland is structurally and functionally two glands in one. The inner adrenal medulla is part of the sympathetic nervous system. When stimulated, it releases epinephrine and norepinephrine, also known as adrenaline and noradrenaline, into the bloodstream. These hormones produce the classic fight-or-flight response, increased heart rate, increased blood pressure, and diversion of blood to the brain, heart, and skeletal muscles. The outer adrenal cortex produces a group of steroid hormones called corticosteroids. One group, the mineralocorticoids, the most important being aldosterone, helps regulate the electrolyte balance in extracellular fluids, primarily by telling the kidneys to reabsorb sodium. The other main group, the glucocorticoids, including cortisol, influences the energy metabolism of most body cells and helps us resist stressors. Cortisol is often called the stress hormone. Now, let's look at the pancreas. The pancreas, located behind the stomach, is both an exocrine and an endocrine gland. Its exocrine function is to produce digestive enzymes. Its endocrine function is carried out by tiny cell clusters called the pancreatic islets, or islets of Langerhans. These islets produce two crucial hormones that regulate blood glucose levels. Insulin, produced by beta cells, is released when blood glucose is high, like after a meal. It lowers blood glucose by enhancing its uptake into body cells and stimulating the liver to store glucose as glycogen. Glucagon, produced by alpha cells, is released when blood glucose is low. It raises blood glucose by stimulating the liver to break down glycogen and release glucose into the blood. The failure of this system is what causes diabetes mellitus. Finally, we have the gonads, the ovaries in females and the testes in males. In addition to producing eggs and sperm, they also produce steroid sex hormones. The ovaries produce estrogens and progesterone, which are responsible for the maturation of the female reproductive organs and the appearance of secondary sex characteristics. The testes produce testosterone, which directs the maturation of the male reproductive organs and secondary sex characteristics and is necessary for normal sperm production. The endocrine system is a beautifully regulated system of chemical communication that maintains homeostasis over long periods. As a nurse, you will care for many patients with endocrine disorders, particularly diabetes and thyroid disease. So a strong foundational knowledge of these glands and their hormones is absolutely essential. Now that we have covered both of the body's major control systems, we're going to move on to the systems responsible for transport and maintenance. We'll start with the river of life itself, the blood. We've explored the body's control systems, the nervous and endocrine systems. Now, we're shifting our focus to the systems that transport, protect, and maintain the body's internal environment. And we're starting with the only fluid tissue in the body, a vital component of the cardiovascular system, blood. Blood is the river of life. It flows through our vessels, transporting everything that must be carried from one place to another within the body. It's a specialized type of connective tissue in which living blood cells, called the formed elements, are suspended in a non-living fluid matrix called plasma. You will be dealing with blood every single day of your nursing career, drawing it, administering blood products, and interpreting lab results like the complete blood count, or CBC. Let's break down its composition. If you were to spin a sample of blood in a centrifuge, it would separate into 3 layers. At the bottom, you'd find the red, dense erythrocytes, or red blood cells. They normally account for about 45% of the total volume of a blood sample, a percentage known as the hematocrit. In the middle, you'd see a thin, whitish layer called the buffy coat. This layer contains the leukocytes, or white blood cells, and platelets. It makes up less than 1% of blood volume. At the top, you'd find the straw-colored liquid plasma, which makes up the remaining 55%. Let's look at each component, starting with the plasma. Plasma is about 90% water. However, it contains over 100 different dissolved solutes, including nutrients, gases, hormones, waste products, and, most importantly, proteins. Plasma proteins are the most abundant solutes, and they serve a variety of functions. Albumin, the most common plasma protein, acts as a carrier for certain molecules and is the major contributor to plasma osmotic pressure, the pressure that helps to keep water in the bloodstream. Other proteins include globulins, which transport lipids and are involved in the immune response, antibodies, and fibrinogen, which is a key protein for blood clotting. Now for the formed elements. First, and by far the most numerous, are the erythrocytes, or red blood cells, RBCs. These are small, biconcave discs. They look like little miniature donuts with a thin center instead of a hole. This shape gives them a huge surface area relative to their volume, which is ideal for gas exchange. Mature RBCs are unique in that they have no nucleus and virtually no organelles. They are essentially just bags of hemoglobin, the protein that binds to and transports respiratory gases. Hemoglobin is made up of the protein globin bound to a red heme pigment. Each hemoglobin molecule can transport 4 molecules of oxygen. A single red blood cell contains about 250 million hemoglobin molecules, so each tiny cell can carry about 1 billion molecules of oxygen. It is the iron atom in the heme group that binds to oxygen. This is why iron is so essential in our diet. A lack of iron can lead to iron deficiency anemia, a condition where the blood has an abnormally low oxygen carrying capacity. When oxygen binds to hemoglobin in the lungs, the hemoglobin becomes bright red. When it unloads oxygen in the tissues, it becomes dark red. This is why arterial blood is bright red and venous blood is dark red. The primary function of RBCs is, therefore, to transport oxygen from the lungs to the tissues and to help transport carbon dioxide from the tissues back to the lungs. Next in the formed elements are the leukocytes, or white blood cells, WBCs. These are the only formed elements that are complete cells with a nucleus and organelles. They are far less numerous than red blood cells, but they are crucial for our defense against disease. They are our mobile army. WBCs are able to slip out of the capillary blood vessels, a process called diapedesis, and move through the tissues to areas of inflammation or tissue damage. There are 5 types of leukocytes, which fall into 2 major categories. The granulocytes, neutrophils, eosinophils, and basophils, have granules in their cytoplasm. Neutrophils are the most numerous WBCs. They are phagocytes, our body's bacteria slayers. Eosinophils lead the attack against parasitic worms and are involved in allergic reactions. Basophils release histamine, an inflammatory chemical that acts as a vasodilator and attracts other WBCs to the site. The agranulocytes, lymphocytes, and monocytes lack visible granules. Lymphocytes, the second most numerous WBC, are the cornerstone of the adaptive immune system. There are 2 types. T lymphocytes, T cells, act directly against virus-infected cells and tumor cells, and B lymphocytes, B cells, give rise to plasma cells, which produce antibodies. Monocytes are the largest leukocytes. When they leave the bloodstream and enter the tissues, they differentiate into highly mobile macrophages, which are voracious phagocytes. Finally, we have the platelets. Platelets are not cells, but rather small, disc-shaped cell fragments of a very large cell called a megakaryocyte. Platelets are essential for the blood clotting process. When a blood vessel is damaged, platelets stick to the exposed collagen fibers and form a temporary plug that helps seal the break. They also release chemicals that are crucial for the subsequent stages of clot formation. Understanding these components is the key to interpreting a CBC. If a patient's hematocrit and hemoglobin are low, they are anemic. If their WBC count is high, it likely indicates an infection. If their platelet count is low, they are at risk for bleeding. Blood is truly a window into a patient's health. Now that we understand the transport medium itself, we need to look at the system that pumps it and the vessels that carry it. Next, we will explore the heart, the unceasing pump at the center of the cardiovascular system. In our last part, we took a deep dive into the composition of blood, the fluid connective tissue that serves as the body's primary transport medium. But this river of life would be a stagnant pond without a powerful pump to keep it moving. Today, we turn our attention to that pump, the heart. The heart is an incredible, cone-shaped muscle, about the size of your fist, located in the chest cavity or mediastinum, just behind the sternum and resting on the diaphragm. It is an unceasing, tireless organ. From before you are born until the moment you die, it contracts rhythmically, pumping blood through about 60,000 miles of blood vessels. Understanding its anatomy is absolutely fundamental to nursing, as cardiovascular disease is the leading cause of death worldwide. The heart is enclosed in a double-walled sac called the pericardium. The outer fibrous pericardium protects the heart and anchors it to surrounding structures. The inner serous pericardium has 2 layers with a film of serous fluid between them, allowing the heart to beat in a relatively friction-free environment. The wall of the heart itself is composed of 3 layers. The outer layer is the epicardium, which is actually the visceral layer of the serous pericardium. The middle layer is the myocardium, which is the thick, muscular layer composed of cardiac muscle. This is the layer that contracts and does the pumping. The inner layer is the endocardium, a glistening white sheet of endothelium that lines the heart chambers and is continuous with the lining of the blood vessels. The heart has 4 hollow chambers, 2 superior atria, singular, atrium, and 2 inferior ventricles. The atria are the receiving chambers. They receive blood returning to the heart from the circulation. The right atrium receives deoxygenated blood from the body via 3 veins: the superior vena cava, the inferior vena cava, and the coronary sinus. The left atrium receives oxygenated blood from the lungs via the 4 pulmonary veins. The ventricles are the discharging chambers, the actual pumps of the heart. When the ventricles contract, they propel blood out of the heart and into the circulation. The right ventricle pumps deoxygenated blood into the pulmonary trunk, which routes the blood to the lungs to be oxygenated. The left ventricle pumps oxygenated blood into the aorta, the largest artery in the body, which distributes it to the rest of the body. Notice that the wall of the left ventricle is much thicker than the right. This is because the right ventricle only has to pump blood to the nearby lungs, the pulmonary circuit. while the left ventricle has to generate enough pressure to pump blood to the entire body, the systemic circuit. To ensure that blood flows in only one direction, the heart is equipped with 4 valves. The 2 atrioventricular AV valves are located between the atria and the ventricles and prevent backflow into the atria when the ventricles contract. The right AV valve is the tricuspid valve, and the left AV valve is the mitral valve or bicuspid valve. Tiny white collagen cords called chordae tendineae anchor the cusps of these valves to the ventricular walls. The 2 semilunar SL valves, the aortic valve and the pulmonary valve, are located at the base of the large arteries leaving the ventricles. They prevent backflow into the ventricles when the ventricles relax. When you listen to a patient's heart with a stethoscope, the lube-dub sounds you hear are the sounds of the heart valves closing. The lube is the AV valves closing, and the dub is the SL valves closing. Let's trace the path of a single drop of blood through the heart. Deoxygenated blood enters the right atrium. It passes through the tricuspid valve into the right ventricle. The right ventricle pumps it through the pulmonary valve into the pulmonary trunk and out to the lungs. In the lungs, the blood releases CO2 and picks up O2. This newly oxygenated blood returns to the heart, entering the left atrium via the pulmonary veins. It passes through the mitral valve into the left ventricle. The powerful left ventricle then pumps the blood through the aortic valve into the aorta, which delivers it to the systemic circulation. This cycle repeats about 75 times every minute at rest. You might be wondering how the heart muscle itself gets its blood supply. The myocardium is too thick to get nutrients by diffusion from the blood inside the chambers. The heart's own circulatory system is called the coronary circulation. The right and left coronary arteries branch off the aorta and supply the heart muscle with oxygenated blood. A blockage in one of these arteries is what causes a heart attack or myocardial infarction. What makes the heart beat? The heart does not need the nervous system to tell it to contract. It has its own intrinsic conduction system, made of specialized cardiac cells that initiate and distribute impulses throughout the heart, ensuring it contracts in an orderly and sequential manner. The process starts at the sinoatrial SA node, located in the right atrial wall. The SA node is the heart's pacemaker. Its cells spontaneously depolarize faster than any other part of the heart, setting the pace for the whole organ. The impulse spreads from the SA node through the atria to the atrioventricular AV node. After a slight delay, the impulse passes to the atrioventricular AV bundle and then down the bundle branches and out into the Purkinje fibers, which penetrate into the ventricular myocardium, causing the ventricles to contract. An electrocardiogram, or ECG, is a graphic record of this electrical activity. The heart is the magnificent engine of life. Knowing its structure and function is non-negotiable for any healthcare professional. Next, we will follow the blood as it leaves the heart and travels through the vast network of blood vessels that permeate every tissue of the body. We've just explored the magnificent anatomy of the heart, the central pump that drives our circulation. But that pump is only effective because it's connected to a closed system of pipes and tubes that deliver blood to every cell in the body and then return it. Today, we're going to study that intricate network of plumbing, the blood vessels. The human body has an estimated 60,000 miles of blood vessels. They are the dynamic delivery routes of the cardiovascular system. We can broadly classify them into 3 main types: arteries, capillaries, and veins. Think of it as a road system. Arteries are the major highways leaving the city, the heart. Capillaries are the tiny residential streets where all the deliveries and pickups happen, and veins are the highways heading back into the city. Let's start with the vessels that carry blood away from the heart, the arteries. Arteries are said to branch, diverge, or fork as they form smaller and smaller divisions. The largest arteries, like the aorta, are called elastic arteries. Their walls contain a lot of elastin, which allows them to expand and recoil as the heart pumps blood into them. This pressure smoothing is what allows blood to flow fairly continuously even though the heart is beating intermittently. Further down the line, we have the muscular arteries, which deliver blood to specific body organs. They have a thick middle layer of smooth muscle, which is very active in vasoconstriction, narrowing of the vessel, and vasodilation, widening of the vessel. This is a major way the body controls blood flow and blood pressure. The smallest arteries are the arterioles, which lead into the capillary beds. The walls of arteries and veins have 3 layers or tunics. The innermost layer is the tunica intima, a smooth lining of endothelium that minimizes friction. The middle layer is the tunica media, made of smooth muscle and elastin. The outer layer is the tunica externa, made of collagen fibers that protect and anchor the vessel. In general, arteries have much thicker walls than veins, especially the tunica media. This is because they have to withstand the high pressure of blood being pumped directly from the heart. When you take a patient's pulse at their wrist or neck, you are feeling the pressure wave expanding and recoiling the wall of an artery. Now for the most important part of the vascular network, the capillaries. Capillaries are the smallest blood vessels, so narrow that red blood cells have to pass through them in single file. They are the link between the arteries and the veins. Their walls consist of just a single, thin layer of endothelium. This incredibly thin wall is by design. Capillaries are the exchange vessels. It is only across their walls that exchanges of gases, nutrients, wastes, and hormones can occur between the blood and the surrounding tissues. Every single cell in your body is within a few cell widths of a capillary. They form extensive, branching networks called capillary beds. After passing through the capillary beds and exchanging their cargo, the blood is now deoxygenated and carrying waste products. It begins its journey back to the heart. The capillaries drain into the smallest veins, called venules, which in turn join to form larger and larger veins. Veins are the vessels that carry blood toward the heart. The walls of veins have the same 3 tunics as arteries, but they are much thinner, and the tunica media contains little smooth muscle or elastin. This is because the blood pressure in the venous system is much, much lower than in the arterial system. By the time blood reaches the veins, most of the pressure from the heart's pumping has dissipated. Because the pressure is so low, veins have large lumens or openings, which offer little resistance to blood flow. This low pressure presents a problem. How does the blood get back to the heart, especially from the lower limbs, against the pull of gravity? The venous system has 2 major adaptations to help with this. First, the larger veins, particularly those in the limbs, have venous valves. These are flap-like structures formed from folds of the tunica intima, and they prevent blood from flowing backward. They work like one-way swinging doors. The second adaptation is the muscular pump. As our skeletal muscles contract and relax, they squeeze the surrounding veins, milking the blood toward the heart. This is why it's so important for patients on bed rest to move their legs or receive regular range of motion exercises to prevent the blood from pooling in their lower limbs, which can lead to clots. As a nurse, you will interact with this vascular system constantly. You'll assess circulation by checking pulses in arteries like the radial artery in the wrist, the carotid artery in the neck, or the dorsalis pedis artery on the top of the foot. You'll measure blood pressure, which is the force the blood exerts on the wall of a brachial artery. And when you start in 4, you'll be accessing a superficial vein, like the cephalic or basilic vein in the arm. So, we have a continuous, closed loop. The heart pumps high-pressure, oxygenated blood into the arteries, which branch into smaller arterioles. These feed into the capillary beds where the vital exchange with the tissues happens. The deoxygenated blood is then collected by venules, which merge into the larger, low-pressure veins, equipped with valves to ensure the blood makes its way back to the heart to be pumped to the lungs and start the cycle all over again. We have this incredible transport system, but it's not the only circulatory system in the body. There's a second, parallel network that works quietly in the background, cleaning up and protecting us. Next, we'll explore the guardian network, the lymphatic and immune systems. We've thoroughly explored the cardiovascular system, the heart, blood, and blood vessels, which acts as the body's main transport network. But as blood circulates through the capillaries, a small amount of fluid inevitably leaks out into the surrounding tissues. If this fluid weren't returned to the bloodstream, we would swell up like a balloon and our blood volume would plummet. The system responsible for collecting this leaked fluid and returning it to the blood is the lymphatic system. Think of the lymphatic system as a parallel, one-way drainage system. It doesn't circulate fluid in a loop like the cardiovascular system. It's a one-way trip from the tissues back to the heart. This system has 3 main functions. First, as we just mentioned, is fluid recovery. It returns interstitial fluid and leaked plasma proteins back to the blood, maintaining blood volume. Second, It plays an essential role in the immune system. And third, it absorbs digested fats from the intestine. Let's look at the components. The system consists of a network of lymphatic vessels, the fluid contained within them, called lymph, and various lymphoid organs and tissues, such as lymph nodes, the spleen, the thymus, and the tonsils. The lymphatic vessels begin as microscopic, blind-ended lymphatic capillaries that are woven between the tissue cells and blood capillaries in the loose connective tissues of the body. These capillaries are remarkably permeable. Their walls are formed by overlapping endothelial cells that create flap-like mini-valves. When the fluid pressure in the interstitial space is higher than the pressure in the lymphatic capillary, these flaps are pushed open, allowing fluid to enter. When the pressure is higher inside, the flaps are pushed shut, trapping the fluid inside. This is how the interstitial fluid, now called lymph, gets into the system. From the lymphatic capillaries, the lymph flows into successively larger vessels, collecting lymphatic vessels, then lymphatic trunks, and finally into one of two large lymphatic ducts in the thoracic region. The right lymphatic duct drains lymph from the right arm and the right side of the head and thorax. The thoracic duct, which is much larger, drains lymph from the rest of the body. These ducts then empty their lymph back into the venous circulation at the junction of the internal jugular and subclavian veins on their respective sides of the body. Like veins, lymphatic vessels are low-pressure conduits and have valves to prevent backflow. The flow of lymph is propelled by the same mechanisms that aid venous return: the milking action of skeletal muscles, pressure changes in the thorax during breathing, and pulsations of nearby arteries. Now, here is where the immune function comes in. As the lymph is transported back toward the heart, it is filtered through hundreds of small, bean-shaped organs called lymph nodes. These nodes are clustered along the lymphatic vessels. Large clusters are found in the inguinal, groin, axillary, armpit, and cervical, neck regions, places you will palpate on your patients. A lymph node has two main functions. First, it acts as a filter. As lymph passes through the node's sinuses, macrophages inside the node remove and destroy microorganisms and other debris, effectively cleaning the lymph before it's returned to the bloodstream. Second, it plays a role in activating the immune system. Lymph nodes are packed with lymphocytes, T cells, and B cells. When lymphocytes encounter antigens, foreign substances, within a lymph node, an immune response is activated. This is why your lymph nodes often become swollen and tender when you're sick. They are overwhelmed with the bacteria or viruses they are trying to fight, a condition called lymphadenitis. Palpating for swollen, tender lymph nodes is a key part of a physical assessment. Other lymphoid organs include the spleen, which is the largest lymphoid organ. It filters and cleanses the blood, removes old and damaged red blood cells, and stores platelets and monocytes. The thymus, located in the chest, is where T lymphocytes mature and become immunocompetent. And the tonsils form a ring of lymphoid tissue around the pharynx. They gather and remove many of the pathogens entering the pharynx in food or in inhaled air. The lymphatic system, therefore, is not just a drainage system. It is the structural basis of the immune system. It provides the housing and transportation for the immune cells, the lymphocytes, macrophages, and others that are constantly patrolling our bodies, ready to detect and destroy foreign invaders. This constant surveillance is what keeps us healthy. When you get a cut on your finger that gets infected, bacteria enter the interstitial fluid. This fluid, along with the bacteria, is picked up by the lymphatic capillaries. It travels up the arm to the axillary lymph nodes, which swell as they mount a powerful attack against the invaders. So, this quiet, unassuming network is our guardian. It maintains our fluid balance and stands as our first and most important line of defense against disease. We've covered transport and defense. Next, we'll move to one of the most fundamental processes for life: obtaining oxygen. We're heading into the anatomy of the respiratory system. We've seen how the cardiovascular and lymphatic systems transport fluids, nutrients, and immune cells throughout the body. But all of our cells, especially our neurons, have a constant, desperate need for one particular substance to produce energy: oxygen. And they need to get rid of a toxic waste product, carbon dioxide. The organ system responsible for this vital gas exchange is the respiratory system. The primary function of the respiratory system is to supply the body with oxygen and dispose of carbon dioxide. To do this, for distinct processes must happen: pulmonary ventilation, breathing; external respiration, gas exchange between the lungs and the blood, transport of respiratory gases via the cardiovascular system; and internal respiration, gas exchange between the blood and the tissue cells. Our focus here in anatomy will be on the structures that make the first two processes possible. The respiratory system can be divided into two zones. The conducting zone consists of all the respiratory passageways that provide conduits for air to reach the sites of gas exchange. These organs also cleanse, humidify, and warm the incoming air. The respiratory zone is the actual site of gas exchange. It's composed of the respiratory bronchioles, alveolar ducts, and alveoli. Let's trace the path of a breath of air. Air enters the system through the nose or mouth. The nose is the preferred entrance because the nasal cavity has several features that prepare the air for the lungs. It's lined with a mucous membrane that is rich in blood vessels, which helps to warm the air. The mucus traps dust and debris, and cilia on the cells sweep this dirty mucus toward the throat to be swallowed. From the nasal cavity, the air passes into the pharynx, or throat, a muscular tube that serves as a common passageway for both food and air. The pharynx is divided into three regions: the nasopharynx, behind the nose; the oropharynx, behind the mouth; and the laryngopharynx, leading to the larynx. From the pharynx, air is routed into the larynx, or voice box. The larynx has three important functions. It provides an open airway. It acts as a switching mechanism to route air and food into the proper channels, and it produces our voice. This switching mechanism is a flap of elastic cartilage called the epiglottis. When we swallow, the larynx is pulled superiorly and the epiglottis tips to cover the laryngeal inlet, routing food down the esophagus behind it. When we breathe, the epiglottis is open. This is why you should never try to talk and swallow at the same time. Below the larynx is the trachea, or windpipe. It's a fairly rigid tube, reinforced by C-shaped rings of hyaline cartilage that prevent it from collapsing and keep the airway open. The trachea is also lined with a ciliated, mucus-secreting membrane that continues to trap debris and sweep it up and away from the lungs. At the level of the mid-thorax, the trachea divides into the right and left main, primary, bronchi, which plunge into the lungs. The right main bronchus is wider, shorter, and more vertical than the left, which is why an inhaled foreign object is more likely to get lodged there. Inside the lungs, the main bronchi subdivide into smaller and smaller branches: lobar bronchi, segmental bronchi, and finally, tiny passages called bronchioles. This extensive branching pattern is often called the bronchial or respiratory tree. As the conducting tubes get smaller, the cartilage rings are replaced by plates of cartilage and then disappear entirely, while the amount of smooth muscle in the walls increases. This smooth muscle allows the bronchioles to constrict or dilate, regulating airflow. This is what goes wrong in an asthma attack. The smooth muscle constricts powerfully, shutting down the airways. Finally, the smallest bronchioles lead into the respiratory zone structures. They terminate in clusters of tiny, thin-walled air sacs called the alveoli. The alveoli are the main event. There are about 300 million of them in our lungs, and their combined surface area is massive, about the size of a tennis court. It is here that the actual gas exchange takes place. The wall of each alveolus is made of a single layer of squamous epithelial cells. This wall is fused to the wall of a pulmonary capillary, which is also a single layer of endothelial cells. Together, the alveolar and capillary walls form the incredibly thin respiratory membrane, across which oxygen and carbon dioxide diffuse with ease. Oxygen passes from the alveolus into the blood, and carbon dioxide passes from the blood into the alveolus to be exhaled. The lungs themselves are soft, spongy, elastic organs that occupy most of the thoracic cavity. The left lung is slightly smaller than the right to accommodate the heart and is divided into two lobes. The right lung has 3 lobes. Each lung is surrounded by a thin, double-layered serous membrane called the pleura. The parietal pleura lines the thoracic wall, while the visceral pleura covers the lung surface. The space between them, the pleural cavity, is filled with a thin film of pleural fluid. This fluid creates surface tension that causes the lungs to cling tightly to the thoracic wall, so they are forced to expand and recoil as the volume of the thoracic cavity changes during breathing. As a nurse, you will be constantly assessing your patient's respiratory system. You'll count their respiratory rate, check their oxygen saturation, and, with your stethoscope, you'll listen to the sound of air moving through this incredible system of tubes, trying to detect any abnormal sounds that could indicate problems like pneumonia, bronchitis, or heart failure. Now that we know how we get oxygen into the blood, we need to look at how we get the other fuel our cells need, nutrients. Next, we will journey down the gastrointestinal tract and explore the processing plant, the digestive system. We've seen how the body acquires the oxygen it needs for cellular energy. Now it's time to look at how it acquires the other essential ingredients, the nutrients, water, and electrolytes found in the food we eat. The organ system responsible for this monumental task is the digestive system. The main function of the digestive system is to take the large, complex food molecules we ingest and break them down into small molecules that are simple enough to be absorbed into the blood. In essence, it's a disassembly line. The process involves 6 essential activities: ingestion, propulsion, mechanical breakdown, digestion, absorption, and defecation. Anatomically, the digestive system consists of 2 main groups of organs. The first is the alimentary canal, also known as the gastrointestinal (GI) tract. This is the continuous, muscular tube that winds through the body from the mouth to the anus. It's the actual disassembly line. The second group is the accessory digestive organs: the teeth, tongue, salivary glands, liver, gallbladder, and pancreas. These organs produce a variety of secretions that help break down foodstuffs. Let's follow a meal on its journey through the alimentary canal. The journey begins at the mouth or oral cavity. Here, ingestion occurs. The teeth begin the process of mechanical breakdown through chewing or mastication. The tongue manipulates the food, and the salivary glands release saliva, which moistens the food and begins the chemical breakdown of carbohydrates with an enzyme called salivary amylase. The food is formed into a soft, compact ball called a bolus. From the mouth, we swallow, and the food is propelled through the pharynx and into the esophagus. The esophagus is simply a muscular tube that carries food from the throat to the stomach. It has no digestive or absorptive function. It moves the food along via waves of muscular contraction called peristalsis. The esophagus passes through the diaphragm and joins the stomach, a J-shaped organ in the upper left part of the abdominal cavity. The stomach acts as a temporary storage tank where chemical digestion of proteins begins and food is converted into a creamy paste called chyme. The muscular walls of the stomach churn and mix the food, continuing the mechanical breakdown. The stomach lining is dotted with gastric pits that lead into gastric glands. These glands secrete a very acidic gastric juice containing hydrochloric acid, which kills most bacteria and helps denature proteins, and pepsin, an enzyme that starts protein digestion. From the stomach, the chyme is slowly released into the small intestine. The small intestine is the body's major digestive organ. It's a long, convoluted tube where digestion is completed and virtually all absorption of nutrients occurs. It has 3 subdivisions: the duodenum, the jejunum, and the ileum. While the small intestine produces some of its own enzymes, most of the digestive work here is done by enzymes produced by the pancreas and bile produced by the liver. To do its job of absorption effectively, the small intestine needs a huge surface area. It achieves this with 3 structural modifications: circular folds, finger-like projections called villi, and tiny projections on the surface of the intestinal cells called microvilli. These 3 features increase the surface area for absorption by more than 600 times. Nutrients pass from the lumen of the intestine across the epithelial cells and into the capillaries and lymphatic vessels within each villus. Now, let's look at the accessory organs that help the small intestine. The liver, the largest gland in the body, has many metabolic roles, but its main digestive function is to produce bile. Bile is a yellow-green, alkaline solution that acts as a fat emulsifier. It breaks large fat globules into smaller ones, which gives the fat-digesting enzymes a greater surface area to work on. The gallbladder is a small green sac that stores and concentrates bile when it's not needed. The pancreas produces a whole host of powerful digestive enzymes that break down all categories of foodstuffs: carbohydrates, proteins, and fats. This pancreatic juice is ducted into the duodenum, where it mixes with the chyme and the bile. After its long journey through the small intestine, All that's left of the food is some water, indigestible materials like fiber, and bacteria. This residue passes into the large intestine. The major functions of the large intestine are to absorb most of the remaining water from the indigestible food residues, store the residues temporarily, and then eliminate them from the body as feces. It frames the small intestine on three sides and consists of the cecum, appendix, colon, ascending, transverse, descending, and sigmoid, rectum, and anal canal. The beneficial bacteria living in our colon help to synthesize some vitamins, like vitamin K. The digestive system is a masterpiece of chemistry and engineering, turning the food we eat into the very fuel and building blocks of our bodies. As a nurse, you'll manage patient nutrition, care for those with GI disorders like Crohn's disease or ulcers, and handle interventions like nasogastric tubes and ostomies, all of which require a solid understanding of this amazing processing plant. Next, we'll look at the system that cleans the blood of the metabolic wastes produced by all this activity, the urinary system. We've seen how the body gets nutrients and oxygen, and how it transports them. But every factory produces waste, and the metabolic factories in our trillions of cells are no exception. The system responsible for filtering these waste products from the blood and eliminating them from the body is the urinary system. While other systems play a role in excretion, the lungs excrete carbon dioxide, the skin excretes some wastes and sweat, and the digestive system excretes indigestible food residues. The urinary system is the body's main excretory system, but it does so much more than just dispose of waste. It's a master regulator of the body's internal environment. Its key functions include regulating the total volume of water in the body and the total concentration of solutes in that water, regulating the concentrations of various ions in the extracellular fluids, ensuring long-term acid-base balance, and producing hormones that regulate red blood cell production and blood pressure. The organs of the urinary system are the kidneys, the ureters, the urinary bladder, and the urethra. Let's start with the workhorses of the system, the kidneys. We have two of these bean-shaped organs located in the superior lumbar region, on either side of the spine. The kidneys are the actual filtration plants. They process the body's entire blood plasma volume more than 60 times each day, consuming a huge amount of oxygen in the process. If you slice a kidney open, you'll see three distinct regions. The outer region is the light-colored renal cortex. Deep to the cortex is the darker renal medulla, which is formed into cone-shaped masses called medullary pyramids. The innermost region is the renal pelvis, a funnel-shaped tube that is continuous with the ureter leaving the kidney. The structural and functional units of the kidneys are the nephrons. There are over 1 million of these tiny blood processing units in each kidney, and they are responsible for forming urine. Each nephron consists of a renal corpuscle and a renal tubule. The renal corpuscle is where the filtration happens. It consists of a tuft of capillaries called the glomerulus, which is surrounded by a cup-shaped structure called the glomerular or Bowman's capsule. Blood enters the glomerulus under high pressure, which forces water and solutes out of the blood and into the glomerular capsule. This raw, unrefined fluid is called filtrate. It's essentially blood plasma without the proteins and blood cells, which are too large to pass through the filtration membrane. From the glomerular capsule, the filtrate enters the long, twisting renal tubule. The tubule has three main parts: the proximal convoluted tubule, the nephron loop, or loop of Henle, and the distal convoluted tubule. As the filtrate flows through this tubule, most of its contents are reclaimed and returned to the blood in a process called tubular reabsorption. Nearly all of the water, glucose, and amino acids are reabsorbed. The rest of the tubule's job is tubular secretion, where certain substances, like some drugs and excess potassium, are actively moved from the blood into the filtrate. This fine-tuning process is what allows the kidneys to precisely regulate blood chemistry. The fluid that is left at the end of the tubule is what we call urine. The urine from many nephrons drains into collecting ducts, which run through the medullary pyramids. From there, it drips into the renal pelvis. From the renal pelvis, urine is carried down to the bladder via the slender tubes called the ureters. The ureters are not just passive tubes. Their walls contain smooth muscle that contracts to propel the urine to the bladder via peristalsis. The urinary bladder is a smooth, collapsible, muscular sac that stores urine temporarily. It's located on the pelvic floor. The bladder is remarkably distensible. A moderately full bladder can hold about 500 milliliters of urine, but it can hold more than double that if necessary. The urethra is a thin-walled muscular tube that drains urine from the bladder and conveys it out of the body. At the bladder-urethra junction, a sphincter of smooth muscle, the internal urethral sphincter, keeps the urethra closed when urine is not being passed. A second sphincter, the external urethral sphincter, is formed of skeletal muscle and is under our voluntary control. The process of emptying the bladder is called micturition or urination. As a nurse, you will be intimately involved with the urinary system. You'll be monitoring your patient's urine output, as it's a critical indicator of their hydration status and renal function. You'll perform procedures like inserting urinary catheters, and you'll care for patients with a wide range of urinary problems, from simple urinary tract infections to complete renal failure requiring dialysis. A solid understanding of this filtration and balancing system is therefore indispensable. We are nearing the end of our journey through the organ systems. Next, we will explore the system that ensures the continuation of our species, the reproductive system. We have now toured nearly every system in the human body, from the control systems to the transport, defense, and maintenance systems. All of these systems work together to keep one individual alive and healthy. The final system we will explore, the reproductive system, is unique. Its primary function is not to ensure the survival of the individual, but to ensure the survival of the species by producing offspring. The reproductive organs of both males and females can be grouped into primary and accessory organs. The primary sex organs, or gonads, the testes in males and the ovaries in females, have two crucial functions. They produce the sex cells, or gametes, sperm and eggs, and they secrete the steroid sex hormones. The accessory reproductive organs are all the other structures, including ducts, glands, and external genitalia. While the male and female systems are different, they share a common goal: to combine their genetic material to create a new human being. In this part, we'll focus on the male reproductive system. The primary role of the male reproductive system is to manufacture male gametes, called sperm, and to deliver them to the female reproductive tract. The primary gonads of the male are the paired testes, singular, testis, which lie within the scrotum. The scrotum is a sac of skin and superficial fascia that hangs outside the abdominopelvic cavity. This external position is essential. Sperm production requires a temperature that is about 3 degrees Celsius lower than core body temperature, and the scrotum provides this cooler environment. Each testis is packed with tiny, coiled tubes called seminiferous tubules. These tubules are the actual sperm factories. It is within these tubes that sperm are produced in a process called spermatogenesis. The testes also have an endocrine function. The cells located in the soft tissue surrounding the seminiferous tubules produce the primary male sex hormone, testosterone. Testosterone is responsible for promoting spermatogenesis and is also what stimulates the development of the male's secondary sex characteristics during puberty. Things like the appearance of pubic axillary and facial hair, deepening of the voice, and an increase in bone and muscle mass. Once produced, the sperm travel through a system of ducts. From the seminiferous tubules, they pass into the epididymis, a comma-shaped organ that arches over the posterior side of the testis. This is where the immature sperm mature and are stored. It takes about 20 days for the sperm to travel through the long, coiled duct of the epididymis, during which time they gain the ability to swim. During ejaculation, sperm are expelled from the epididymis into the ductus deferens, also called the vas deferens. This tube runs up from the scrotum into the pelvic cavity and arches over the urinary bladder. The ductus deferens propels live sperm from their storage sites into the urethra. The surgical procedure known as a vasectomy involves cutting and ligating the ductus deferens, which prevents sperm from reaching the urethra, making a man sterile. The ductus deferens joins with the duct of the seminal gland to form the short ejaculatory duct, which passes through the prostate and empties into the urethra. In males, the urethra serves as the terminal duct for both the urinary and reproductive systems, conveying both urine and semen out of the body, though not at the same time. Sperm are only one component of the fluid that is ejaculated. The bulk of semen is a mixture of sperm and secretions from the accessory glands. These glands include the seminal glands, the prostate, and the bulbourethral glands. Their secretions provide a transport medium and nutrients for the sperm, and they contain chemicals that protect and activate the sperm and facilitate their movement. The paired seminal glands on the posterior bladder surface produce a viscous, alkaline seminal fluid containing fructose, which provides energy for the sperm. The single prostate, a donut-shaped gland that encircles the urethra just inferior to the bladder, secretes a milky, slightly acidic fluid that plays a role in activating sperm. The tiny, pea-sized bulbourethral glands produce a thick, clear mucus prior to ejaculation that lubricates the gland's penis and neutralizes traces of acidic urine in the urethra. The penis, along with the scrotum, makes up the external genitalia of the male. The penis is the male copulatory organ, designed to deliver sperm into the female reproductive tract. It consists of a root, a shaft, and an enlarged tip called the glans penis. Internally, the penis contains the urethra and 3 cylindrical bodies of erectile tissue. During sexual excitement, these erectile tissues fill with blood, causing the penis to enlarge and become rigid, an event called an erection. Understanding male reproductive anatomy is important for nurses, as you will encounter patients with a variety of related health issues, such as benign prostatic hyperplasia, BPH, which is an enlargement of the prostate gland that can make urination difficult, as well as prostate cancer and testicular cancer. Now that we've seen how the sperm are produced and prepared for their journey, we'll explore the female reproductive system next to understand where that journey leads and how new life begins. In our last part, we explored the male reproductive system, which is designed to produce and deliver sperm. Today, we turn our attention to its counterpart, the female reproductive system. The female system is more complex, as it not only has to produce the female gametes, or ova, eggs, but it must also be prepared to receive sperm, provide the ideal environment for fertilization, and then nurture a developing fetus for 9 months, and finally, give birth. The primary sex organs, or gonads, of the female are the paired ovaries. These almond-shaped organs are located on either side of the uterus in the pelvic cavity. The ovaries have 2 key functions. First, they produce the female gametes, the ova, in a process called oogenesis. Second, they are endocrine organs, producing the female sex hormones, primarily estrogens and progesterone. Unlike males, who produce sperm continuously from puberty onward, a female is born with all the eggs she will ever have. These immature eggs are housed within tiny sac-like structures in the ovary called follicles. Starting at puberty, each month, one of these follicles is selected to mature, and its egg is released from the ovary in an event called ovulation. Once an egg is ovulated, it is typically swept into a uterine tube, also known as a fallopian tube or oviduct. These tubes are the initial part of the female duct system. They are not directly connected to the ovaries, but have finger-like projections called fimbriae that create currents to pull the ovulated egg into the tube. The uterine tubes are the site where fertilization usually occurs. The egg is carried toward the uterus by a combination of peristalsis and the beating of cilia. The uterine tubes lead to the uterus, or womb. The uterus is a hollow, thick-walled, muscular organ shaped like an inverted pear. It is located in the pelvis, anterior to the rectum and posterior-superior to the bladder. The major function of the uterus is to receive, retain, and nourish a fertilized ovum. If fertilization occurs, the embryo implants in the wall of the uterus and resides there for the rest of its development. The wall of the uterus is composed of 3 layers. The outer layer is the perimetrium. The middle layer is the thick myometrium, made of interlacing bundles of smooth muscle. This layer contracts rhythmically during childbirth to expel the baby. The innermost layer is the endometrium. This is a mucosal lining that a fertilized egg burrows into for implantation. The endometrium has 2 layers. The deeper layer is stable and doesn't change much. The superficial functional layer, however, undergoes cyclic changes each month in response to ovarian hormones. It thickens in preparation for implantation, and if pregnancy does not occur, this layer is shed during menstruation. The narrow neck, or outlet, of the uterus, which projects into the vagina, is the cervix. The cervical canal connects the uterus to the vagina. The vagina is a thin-walled tube that lies between the bladder and the rectum. It extends from the cervix to the body exterior. The vagina provides a passageway for the delivery of an infant and for menstrual flow, and it is the female organ of copulation, receiving the penis and semen during intercourse. The female reproductive structures that lie external to the vagina are called the external genitalia, or the vulva. These include the mons pubis, the labia majora and minora, and the clitoris. The female reproductive cycle is a complex interplay of hormones from the hypothalamus, anterior pituitary, and ovaries. The monthly cycle of events that matures an egg and prepares the uterus for pregnancy is called the ovarian cycle and the uterine, or menstrual, cycle. These two cycles are hormonally coordinated. Ovarian hormones, estrogen and progesterone, drive the changes in the uterine lining. On average, the cycle is about 28 days long, with ovulation occurring around day 14. Finally, though they are not reproductive organs in the strictest sense, the mammary glands are considered accessory reproductive organs. These glands are present in both sexes, but normally function only in females. Their biological role is to produce milk to nourish a newborn infant, a process called lactation. The mammary glands are modified sweat glands that consist of 15 to 25 lobes that radiate around and open at the nipple. Knowledge of female reproductive anatomy is vital for nurses in many specialties, from labor and delivery to gynecology and oncology. You will be involved in health teaching about contraception and menstrual health, assisting with procedures like pap smears, which screen for cervical cancer, and caring for patients throughout pregnancy and childbirth. This completes our tour of the individual organ systems. But the real magic of the human body is not in how these systems work alone, but in how they work together. In our final parts, we will put it all together and see the body as the integrated, magnificent whole that it is. For the past 22 segments, we have been on an incredible journey. We started with a single point of reference, the anatomical position, and from there, we explored the body layer by layer, system by system. We zoomed into the microscopic world of cells and tissues, and then zoomed back out to see how they form the complex architecture of our organs. We've studied the skeletal framework, the muscular engines, the nervous control centers, the endocrine chemical messengers, the cardiovascular transport lines, the respiratory gas exchange, the digestive processing plant, the urinary filtration system, and the reproductive blueprint for the future. It can be tempting, especially when you're studying for exams, to think of these as 11 separate, isolated chapters in a textbook. The cardiovascular system is one test, the respiratory system is another. But that is not how the human body works. The single most important concept to take away from this entire series is that of integration. No organ system works in isolation. They are all profoundly and beautifully interconnected, constantly communicating and cooperating to maintain the stable internal environment that we call homeostasis. Anatomy provides the map, and physiology explains the traffic, but true clinical understanding comes from seeing how a traffic jam in one part of the city causes problems all over the map. This is the foundation of your clinical reasoning as a nurse. Let's think about this with a simple example: exercise. When you decide to go for a run, you are consciously using your nervous system, specifically the somatic motor division, to send signals to the skeletal muscles of your muscular system. As your muscles begin to contract more forcefully and frequently, their demand for ADP skyrockets. To produce this ADP, your muscle cells need more oxygen and need to get rid of the extra carbon dioxide they are producing. This information is relayed back to your brainstem. In response, your CNS sends signals via the autonomic nervous system to ramp up the respiratory system. Your breathing rate and depth increase to bring more oxygen into the lungs and expel more CO2. Simultaneously, your cardiovascular system kicks into high gear. Your heart beats faster and more forcefully, pumping more blood with each beat. This increases blood flow, delivering that freshly oxygenated blood from the lungs to the working muscles more quickly. Your blood vessels in the muscles dilate to accept this increased flow, while vessels in your digestive organs might constrict, shunting blood to where it's needed most. But all this activity generates a lot of heat. To prevent your core temperature from rising to dangerous levels, your integumentary system gets involved. Your brain signals sweat glands to release sweat, and the evaporation of this sweat cools your skin. Blood flow to the skin also increases, allowing heat to radiate away from the body. Meanwhile, your endocrine system is also responding. Your adrenal glands release epinephrine and norepinephrine, which further enhance heart rate and breathing, and your pancreas adjusts insulin and glucagon levels to ensure your muscles have a steady supply of glucose for fuel. Your urinary system conserves water to compensate for what you're losing through sweat. And your skeletal system is providing the levers and the stable framework for all this movement. In that single act of going for a run, nearly every organ system in your body is working in a perfectly coordinated symphony. It is a breathtaking example of integration. Now, let's consider what happens when one system fails. This is the reality of pathophysiology and the world you are entering as a nurse. A problem in one system will inevitably cause ripple effects throughout the entire body. If a patient's kidneys fail, urinary system, they can no longer excrete waste products, which build up to toxic levels in the blood, cardiovascular system, and can damage the brain, nervous system. They can't regulate electrolytes like potassium, and high potassium levels can cause fatal cardiac arrhythmias, cardiovascular system. They can't regulate fluid balance, leading to fluid overload, high blood pressure, and fluid backing up into the lungs, making it difficult to breathe, respiratory system. One system failing creates a cascade of crises in all the others. This is why your study of anatomy is so much more than memorization. It's about building a mental model of the human body. It's about understanding the intricate connections and dependencies. When you walk into a patient's room, you are not just seeing a cardiac patient or a respiratory patient. You are seeing a whole, integrated person whose systems are all interacting. Your anatomy knowledge is the map that will allow you to navigate the complexity of their condition, to understand their symptoms, to anticipate potential complications, and to understand why the interventions you are performing actually work. In our next part, we're going to make this even more concrete by walking through a clinical case study, seeing how this integrated knowledge plays out in a real-world nursing scenario. Welcome to our penultimate session. We've established the critical importance of seeing the body as an integrated whole. Now, let's put that principle into practice. Theory is one thing, but seeing how it applies to a real person is what makes this knowledge come alive. We're going to walk through a hypothetical, but very typical, clinical scenario. I want you to actively think about the anatomy we've discussed as we go. Let's meet our patient. We'll call him Mr. Harrison. He is a 68-year-old man who has been brought into the emergency department by his family. His chief complaint is severe shortness of breath. He says it's been getting worse for a few days, and now he can even walk from his living room to his kitchen without feeling like he is suffocating. He's also noticed that his feet are very swollen and his shoes don't fit. You are the nurse assigned to Mr. Harrison. Your assessment begins. The first thing you do is take his vital signs. His heart rate is 110 beats per minute, tachycardia. His respiratory rate is 28 breaths per minute, tachypnea. His blood pressure is 160/95 mmHg, hypertension, and his oxygen saturation on room air is 88%. Let's stop and think anatomically. His high heart rate and respiratory rate are compensatory mechanisms. His body is sensing a lack of oxygen, so the nervous system, specifically the brainstem, is telling the cardiovascular and respiratory systems to work harder to try and make up for the deficit. The low oxygen saturation tells you that despite this effort, the gas exchange at the respiratory membrane in his alveoli is not effective. Now, you begin your physical assessment. You look at Mr. Harrison. He is sitting upright in bed, leaning forward on his arms. This is called the tripod position. Anatomically, why is he doing this? He is using his accessory muscles of respiration in his neck and chest to help lift his rib cage, trying to increase the volume of his thoracic cavity to get more air into his lungs. This is a classic sign of respiratory distress. You look at his neck and you notice that his jugular veins are bulging. This is called jugular venous distension, or JVD. Let's connect this to anatomy. The jugular veins drain blood from the head back to the superior vena cava, which empties into the right atrium of the heart. If these veins are backed up and bulging, it's like a traffic jam on the highway leading back to the heart. It tells you that the pressure in the right side of his heart is very high, and the heart is not effectively pumping the blood that is returning to it. Next, you get out your stethoscope to listen to his lungs. You place it on his back, over the posterior aspects of the lower lobes. Instead of hearing clear air movement, you hear a crackling sound, like Velcro being pulled apart. These are called crackles, or rales. What does this tell you anatomically? This sound is caused by air trying to move through small airways and alveoli that are filled with fluid. His respiratory zone, the site of gas exchange, is waterlogged. This is why his oxygen saturation is low. Oxygen cannot diffuse efficiently across a respiratory membrane that is thick with fluid. Then, you move your stethoscope to his chest to listen to his heart. In addition to the fast rate, you hear an extra heart sound, a lub-dub dub rhythm. This is called an S3 gallop, and it is often a sign that the ventricles are overfilled and struggling to handle the volume of blood. Finally, you assess his legs, as he mentioned they were swollen. You press your thumb firmly into the skin over his shin for a few seconds. When you pull it away, a deep indentation remains. This is called pitting edema. Let's think about the anatomy here. We know that fluid from the blood normally leaks out into the interstitial space at the capillary level. The lymphatic system and the pressure gradient in the veins are supposed to return this fluid to the circulation. This severe edema tells you two things. First, the pressure in his venous system is extremely high, forcing excessive amounts of fluid out of the capillaries. Second, the system is so overwhelmed that the fluid is just accumulating in the tissues of his integumentary system. So, without even looking at a lab result or a chest X-ray, your knowledge of anatomy has allowed you to piece together a compelling story. Mr. Harrison's heart is failing as a pump. This is causing blood to back up into the venous system, causing the JVD and edema, and back up into the lungs, causing the crackles and shortness of breath. His body is trying to compensate, but it's a losing battle. You have just identified the classic signs and symptoms of congestive heart failure. Your anatomical knowledge didn't just help you perform the assessment. It helped you understand what you were seeing and hearing. In our final part, we'll see how the diagnosis is confirmed and how the treatments for Mr. Harrison are all directly targeted at the anatomical and physiological problems we've just uncovered. Welcome to the final part of our comprehensive series on human anatomy for nursing students. We've come a long way, from the simplest directional terms to the complex integration of organ systems. Let's return to our patient, Mr. Harrison, and see how your anatomical knowledge will guide his care and solidify your understanding of the human body. Based on your expert assessment, the physician orders a chest X-ray and some blood work. The X-ray comes back and confirms your suspicion. It shows fluid in the lungs, pulmonary edema, and an enlarged heart, cardiomegaly. The blood work shows elevated levels of a substance called brain natriuretic peptide, BNP, a hormone released by overstretched heart muscle cells. The diagnosis is confirmed. Mr. Harrison is in an acute exacerbation of congestive heart failure. Now, let's look at the treatments ordered and understand them through the lens of anatomy. The physician orders a potent diuretic, like furosemide. How does this work? Diuretics target the urinary system. Specifically, they work on the renal tubules of the nephrons in the kidneys. They inhibit the reabsorption of sodium, and because water follows salt, this causes the kidneys to excrete large amounts of sodium and water as urine. By removing excess fluid from the body, you are reducing the total blood volume. This decreases the amount of blood returning to the heart, which lessens the workload on the failing pump. It also helps to pull the excess fluid out of his lungs and his legs, which will relieve his shortness of breath and his edema. You are directly manipulating the filtration and reabsorption functions of the kidney to help the failing heart. Next, the physician orders a vasodilator, like nitroglycerin. How does this work? Vasodilators target the smooth muscle in the tunica media of the blood vessels. Nitroglycerin primarily dilates the veins. By widening these vessels, you increase the capacity of the venous system to hold blood, which further reduces the amount of blood returning to the heart, a property called reducing preload. Some vasodilators also work on arteries, making it easier for the heart to pump blood out against less resistance, reducing afterload. Again, you are using your knowledge of the vascular system to make the heart's job easier. Finally, Mr. Harrison is placed on supplemental oxygen via a nasal cannula. This addresses the problem in his respiratory system. While the ultimate goal is to get the fluid out of his lungs, in the short term, you can improve his oxygen saturation by increasing the concentration of oxygen in the air he inhales. This creates a steeper pressure gradient for oxygen to diffuse across the fluid-filled respiratory membrane in his alveoli, getting more oxygen into his blood. Do you see the integration? A problem with the heart, cardiovascular system, is treated with drugs that target the kidneys, urinary system, and the blood vessels, cardiovascular system, and is supported by an intervention for the lungs, respiratory system. This is what it means to be a nurse. You are not just following orders. You are understanding the deep anatomical and physiological reasons why these orders work. This is the power of the knowledge you have started to build. Anatomy is not a subject you learn and forget. It is the language of medicine. It is the map you will use every single day to navigate the complexities of human health and disease. It is the foundation upon which all of your other nursing skills, assessment, critical thinking, intervention, will be built. Our journey through the human body is now complete, but your journey as a nursing student is just beginning. There will be times when you feel overwhelmed by the sheer volume of information. When that happens, I want you to come back to these fundamentals. Remember the logic. Remember the connections. Remember that every complex disease process is ultimately a disruption of the beautiful, orderly anatomy we have explored together. You are stepping into a profession that is challenging, rewarding, and profoundly important. You will be the one at the bedside, using this knowledge to assess, to comfort, and to heal. The map is now in your hands. Study it well, use it wisely, and never lose your sense of wonder at the incredible machine that is the human body. Thank you for joining me on this journey. Go out there and be the exceptional nurse you are destined to be. Good luck.